So this is a recapitulation from the previous day's class. We shall be covering up spinal cord, its section, different varieties of section, spinal shock, vestibular apparatus. This is our total target today, which we will be covering up. Coming to this one, just a recapitulation. So if you remember, this side is the dorsal, this side is the ventral. Ventral is for the motor and dorsal is for the sensory. There are basically three horns. One is the, what is this horn? Anterior horn. What is this horn? Posterior horn. And what is this horn? Lateral horn. And these horns were connected with various motor activities or sensory activities or autonomic activities. So anterior horn is connected with, anterior horn ki supply korche kisher? Motor. Posterior horn or dorsal horn? Sensory. And this lateral horn? Autonomic. Lateral horn autonomic. আগের দিন যেখানটায় শেষ হয়েছিল ওই জায়গা থেকে we will draw the picture again এবং সেই জায়গা থেকে আবার আমরা এগোবো. So lateral horn is for the autonomic. Now this is the autonomic ganglia. This one is the autonomic ganglia. You can see either side we do have some autonomic ganglia. And this autonomic ganglia is connected with the lateral horn. আগের দিন আমরা যেগুলো বলেছি, that was sensory we have discussed conscious sensory, conscious motor. We have discussed unconscious sensory, unconscious motor. এর সঙ্গে আজকে থাকছে another unconscious sensation, that is the autonomic sensation, and that is regulated and passed through the lateral horn and passed through the autonomic ganglia. That's the process. Now if we look at the whole thing, this is the area of and fasciculus gracilis. These are present over there. Gracilis works through or from the legs, lower limbs, cuneatus from the upper limbs. This is about the conscious. This is about the conscious sensation. What are the sensation? That dorsal column. কি আছে sensation dorsal column যেগুলো ইউজ করছে? Vibration, two point discrimination, stereognosis, joint position, proprioception. এই জিনিসগুলো আমাদের dorsal column নিয়ে যাচ্ছে. So anyway, and এই জায়গাতে আমাদের থাকছে কি? Descending tract. Left side এ descending both side এই রয়েছে. Just for the, I mean at different layers, descending and ascendings are there. দুটো সাইডেই আছে, মেকিং ইট সিম্পল ফর দ্য সেক অফ সিম্পলিসিটি। এক সাইডে আমরা মোটর রাখছি, এক সাইডে সেন্সারি রাখছি। আছে কিন্তু দু সাইডে, এমন নয় যে রাইট সাইড ইজ অনলি হ্যাভিং সেন্সারি, লেফট সাইড ইজ অনলি হ্যাভিং দ্যাট। বাট একটা সিন্স দিস ইট ডাজন্ট হ্যাভ আ ডেপথ ইন দ্য পিকচার, আই ক্যান শো ইউ। ওকে, সো দিস ইজ ডিসেন্ডিং ট্র্যাক্ট যেটা যাচ্ছিল, অ্যান্ড রিমেম্বার দিস ডিসেন্ডিং ট্র্যাক্ট ফর দ্য ল্যাটারাল অ্যান্ড ডিস্টাল, সো বেসিক্যালি ফর দ্য লিম্বস। ডিসেন্ডিং ট্র্যাক যেটা যাচ্ছে এই জায়গাতে, যে ডিসেন্ডিং ট্র্যাকটা যাচ্ছে, দ্যাট ইজ corticospinal, this for the limbs, whereas conscious descending tract is also going through this, that is actually anterior, that was lateral corticospinal. উপরেরটা ছিল lateral corticospinal, that is for the distal part, and this is anterior corticospinal, নিচে যেটা এঁকেছি, that is for the proximal and trunk descending tract. আর যেটা যাচ্ছে এখান দিয়ে, apart from that, this is for the extrapyramidal system. This is for the extrapyramidal tract. This is pyramidal tract. This is pyramidal tract. This is pyramidal tract for distal. This is pyramidal tract for proximal. This is extrapyramidal tract for distal. This is extrapyramidal tract for proximal. And if you remember, multiple times these things will come. Extrapyramidal tract is for the involuntary movement. So whenever something is happening, you are catching a cricket ball at silly mid-off, you are catching a cricket ball, you short leg, you are catching a cricket ball, you don't have time to think, but you are still being able to catch it. This is through the extrapyramidal system, through the cerebellar system, most likely visual system, অনেক সময় দেখাও যায় না, still the fielder is able to catch the ball, that is through this extrapyramidal system. Pyramidal system হচ্ছে আমি ভাবছি, হাঁটছি, this is pyramidal system. আমি ভাবছি হাতটা উপরে যাবে নিচে যাবে, আমি চিন্তা করছি, আই এম মাইসেলফ গিভিং আ ভলান্টারি কমান্ড টু মাইসেলফ। এই জিনিসটা হচ্ছে পিরামিডাল সিস্টেম। সেটার স্পেটিয়াল অর্গানাইজেশন রয়েছে। আবার যদি আরো আগের ইয়েতে চলে যাই, ইট ইজ স্টার্টিং ফ্রম দি কর্টেক্স। কর্টেক্সের মধ্যে পিরামিডাল সিস্টেমের মোটর কর্টেক্স, motor cortex has multiple area, multiple layer like primary motor, premotor, supplementary motor. এদের মধ্যে প্রাইমারি মোটর, প্রি মোটর, দে ডু হ্যাভ আ লিটল বিট অফ সোমাটোট্রফিক অর্গানাইজেশন। প্রাইমারি মোটরটা পুরোটাই সোমাটোট্রফিক অর্গানাইজেশন, which is basically the homunculus, we call it motor homunculus. Similar thing is present in the back side, that means posterior to the central sulcus for the sensory system. তার আবার সেন্সারি হোমানকুলাস রয়েছে। অ্যান্ড সোমাটোট্রপিক সেন্সারি হোমানকুলাস আগের দিন আমি ছবিতে সব দেখিয়েছি। আই থিঙ্ক বাই নাও ইউ হ্যাভ দি আন্ডারস্ট্যান্ডিং দ্যাট সার্টেন এরিয়াস অফ দ্য বডি হ্যাজ গ্রেটার রিপ্রেজেন্টেশনাল এরিয়া ইন কর্টেক্স, certain greater area, surface area, but have lesser representational area in the cortex. So this is all about the homunculus. Homunculus kind of a map depending on the influence and finesse of the function done by that particular organ or surface. Clear? So far clear. এবার যদি আরেকটু এদিকটাতে চলে আসছি, এইখান দিয়ে আমাদের this is unconscious sensation, unconscious sensation, and it was spinocerebellar, spinocerebellar, unconscious sensation. তুমি ট্রেনে করে যাচ্ছ, হঠাৎ করে হাওয়া লাগছে মুখে, ঠান্ডা হাওয়া, মাথাটা সরিয়ে নিলে কিভাবে হবে? আনকনসিয়াস। এর সাথে উইথড্রল রিফ্লেক্সও রয়েছে টু সাম এক্সটেন্ট, বাট বুঝতে পেরে আনকনসিয়াস সেন্সেশন। অনেক সময় আমরা মুভ করছি, মুভ করতে করতে ইন বিটুইন মেনি থিংস আর বিং চেঞ্জড, সেই সময় বডিকে সেইভাবে যে চেঞ্জ হচ্ছে, দ্যাট ইজ ডিউ টু দি আনকনসিয়াস সেন্সেশন। ধরো কেউ এটা উপর থেকে নিচে লাফ দিচ্ছে অ্যান্ড মাল্টিপল লেয়ার্স অফ অবস্ট্রাকশন হি ইজ পাসিং থ্রু, সেই সময় ডেফিনেটলি গ্র্যাভিটি উইল হ্যাভ দ্য গ্রেটার সে, নিচে পড়ে যাবেই, বাট স্টিল যখন অবস্ট্রাকশন গুলোতে হিট করছে বডি, বডি ইজ মেকিং সাম অ্যাডজাস্টমেন্ট অ্যাট লিস্ট, এটাও আনকনসিয়াস সেন্সেশন। তো এই জাতীয় জিনিসগুলো উই ক্যান ফাইন্ড আউট, অ্যান্ড দিস হ্যাপেন্স থ্রু দিস স্পাইনোসেরিবেলার ট্র্যাক্ট। সো সিমিলার স্পাইনোসেরিবেলার ট্র্যাক্ট দিয়েও সেই পাথওয়েগুলোই যায় ডরসাল কলাম দিয়ে যেটা যায়, বাট ডরসাল কলাম ইজ কনসিয়াস সেন্সরি, স্পাইনোসেরিবেলার ইজ দি আনকনসিয়াস সেন্সরি। ক্লিয়ার হয়ে যাচ্ছে জায়গাগুলো? আচ্ছা, এখানে আরেকটা ছিল, এই জায়গাতে আমাদের থাকছে হচ্ছে স্পাইনোথ্যালামিক। স্পাইনোথ্যালামিক নামগুলো মনে রাখলেই হবে, নিউরোলজি ইজ জাস্ট লাইক ম্যাথমেটিক্স, অ্যান্ড প্রত্যেকটা নামেই ইন দি ইফ ইউ জাস্ট ব্রেক ডাউন, অ্যানালাইজ দ্য নেম, ইউ ক্যান আন্ডারস্ট্যান্ড কোথা থেকে শুরু হচ্ছে। The origin is written as a prefix and the destination is written as a suffix, kind of that in that particular word. So word guloke bhangle you will get the neurological things. So this is spinothalamic, so it means it starts from the spinal and goes to the thalamus. What is thalamus? Thalamus is the sensory relay system. So whatever is happening, thalamus, if it is there, it is a sensory system, and definitely it is an ascending system. Ascending means sensory, more or less. Descending মানে motor, more or less, because command is coming from here, sensation is coming from there. That's the whole idea. So they এইটা হচ্ছে lateral spinothalamic tract, সেটা এখান দিয়ে যাচ্ছে। কিভাবে যায় lateral spinothalamic tract? কোথা দিয়ে ঢুকছে? সেন্সরি কোথা দিয়ে আসে, অ্যান্টেরিয়র না পস্টেরিয়র? তাহলে ডরসাল দিয়ে আসছে, ডরসাল দিয়ে আসছে, ডরসাল দিয়ে এসে কোথায় যাচ্ছে? ডেকাসেক্ট করছে। তো ডরসাল দিয়ে এসেই অপোজিট সাইডে কিন্তু চলে যাওয়ার কথা, ডরসাল দিয়ে এসেই অপোজিট সাইডে সেন্সরিটা কিন্তু চলে যাচ্ছে। রিমেম্বার, অ্যাট দ্যাট লেভেল, ইন সাম কেসেস 1 or 2 লেভেল হায়ার অর লোয়ার, কিপিং ইট সিম্পল অ্যাট দ্যাট লেভেল। একদম এইটা মাথায় রাখলেই হবে। কিছু ক্ষেত্রে আপ ডাউন একটু হয়, বাট রাইট নাও ফর সিম্পলিসিটি উই আর কিপিং ইট সিম্পল। তো এই দিক থেকে গিয়ে সেম লাইনে ল্যাটারাল স্পাইনোথ্যালামিক ট্র্যাক্ট দিয়ে উপরের দিকে চলে যাচ্ছে। কি নিয়ে যায় এই ল্যাটারাল স্পাইনোথ্যালামিক ট্র্যাক্ট? Sensation, pain and temperature. Sensation is pain and temperature. Clear everybody? অবধি আমরা যেগুলো বললাম ক্লিয়ার? আরেকটা হচ্ছে লাস্ট যেটা, এইখান থেকে this is the direction of the autonomic thing. This is the direction, এই যে ল্যাটারাল হর্ন থেকে স্টার্ট হবে, ল্যাটারাল হর্ন থেকে ভেন্ট্রালটা দিয়ে অটোনমিক গ্যাংলিয়া অবধি যাবে। This is the direction of the autonomic command. Clear everybody? This is the direction of the autonomic command. তাহলে মোটামুটি এই আইডিয়াটা হলো, দিস ইজ জাস্ট দি রিক্যাপিচুলেশন ফ্রম দি প্রিভিয়াস ডে। সো we will be moving forward from here. Okay, now we will be coming to a very interesting thing that can happen if so suppose spinal cord at a particular level is destroyed, obstructed, damaged. Either or. Destroyed, obstructed, damaged, maybe a tumor, maybe some infection, maybe a stroke in that area, maybe ischemia, whatever. So spinal cord is fully damaged. It is called as transection of spinal cord. It is transection. বইতে প্রচুর কোশ্চেন দেখবে যে this is transection of the spinal cord, মানে কি ফুল সেকশনটা চলে গেছে উপর অবধি। এইটা যদি সেকশনটা যায় তার উপরের all the spinal cord segments are okay, নিচের spinal cord segments are also okay. Unfortunately one segment is gone. It may be damaged, may be denervated, may be compressed, whatever pathology, that is not required at this point. You just try to understand that the whole spinal cord is damaged. What will happen? গোটা spinal cord টা বেরিয়ে গেছে, গোটা paralysis. Okay, what kind of paralysis? কোথায় পেশেন্টের মধ্যে কি চেঞ্জ আসছে? Any idea? পেশেন্টের মধ্যে কি চেঞ্জ আসছে? দুটো জিনিস খুব ক্লিয়ারলি এই জায়গাগুলোকে বোঝো। ব্রেনে লেফট হেমিস্ফিয়ার, সেখানে ইন্টারনাল ক্যাপসুল, অ্যানাটমি হচ্ছে তো সাইমালটেনিয়াসলি চলছে তো, এগুলো ইন্টিগ্রেট করার জায়গা অ্যাকচুয়ালি। এভরিবডি ক্যান আন্ডারস্ট্যান্ড? ব্রেনে ইন্টারনাল ক্যাপসুল 9:30 হলেই আমাদের ভেস্টিবুলার ধরতে হবে, জাস্ট লেট মি নো, কেউ একজন বলে দিও, নইলে আই কান্ট ফিনিশ। সো টিল দেন উই উইল বি কন্টিনিউইং দিস স্পাইনাল কর্ড। Okay, that is again another very difficult area, vestibular nucleus and vestibular apparatus basically, সেটা শুরু করব আজকে। সো ব্রেনে তোমার ইন্টারনাল ক্যাপসুলে একটা ইসচেমিক কোনো লিশন হয়েছে, এনি লিশন, ইসচেমিক, হেমারেজিক, হোয়াটএভার, ইন্টারনাল ক্যাপসুলের থ্রু দিয়ে যেগুলো আসছে মোটর পাথওয়ে, ইটস নট ওয়ার্কিং এনিমোর ডিউ টু সাম রিজন, and it is happening on the left side. তুমি প্রশ্ন করতে পারো কেন দুদিকে নয় কেন? বিকজ দুটো কর্টেক্স আলাদা, দুটো ব্রেনে দুটো হেমিস্ফিয়ার রয়েছে, সেরিব্রাল দুখানা হেমিস্ফিয়ার রয়েছে। ইউজুয়ালি দুদিকে কি একসাথে হতে পারে না? পারে, বাট দ্যাট ইজ ভেরি রেয়ার। ইউজুয়ালি হোয়াট উই সি থিংস, তোমার যেমন হাতে ব্যথা হচ্ছে, দুটো হাত একসাথে ব্যথা হবে না, কোথাও একটা সাইডেই ম্যাক্সিমাম টাইমে হবে। দুদিকে হতে পারে, পারে, বাট মোস্ট অফ দি টাইম আমরা যেটা দেখি যেগুলো স্ট্রোক প্যাথোলজি, আমাদের একটা সাইডে ট্রাবলটা এসেছে, একটা সাইডে আইদার থ্রম্বোটিক প্যাথোলজি অর এম্বলিক প্যাথোলজি or hemorrhagic pathology. Thrombotic pathology মানে ছোট ছোট thrombus, small thrombus are occluding the smaller vessels inside the brain. That can happen in a diabetic patient, in a hyperlipidemic patient, in a patient with multiple other comorbidities. Embolic pathology মানে embolus, it is also an obstructive thing, kind of a thrombus that has been formed anywhere in the body and then that is dislodged to the brain. থ্রম্বোসিসটা সেই জায়গাতে হচ্ছে লোকাল এরিয়াতে, এমবোলাস হচ্ছে একটা ক্লট যেটা অন্য জায়গায় তৈরি হয়েছিল and it dislodged to the brain. Usually that requires bigger pathway. তোমার একটা জিনিস বোঝার চেষ্টা করো, সুয়েজ ক্যানাল সেটা যদি সরু হয়ে যায়, it will not help ships passing by. তাহলে embolic events is actually a larger vessel event. বড় ডায়ামিটার না থাকলে এমবোলাস পাস করবে না। সো ইট ইজ ইউজুয়ালি আ লার্জার অর্গান, ইউজুয়ালি যেখানে হয় আইদার তোমার লাংসে হচ্ছে, বাট ম্যাক্সিমাম টাইমে যেটা পাওয়া যায় ইন দ্য হার্ট, এমবোলাস ফর্ম হচ্ছে, ওখানে একটা তৈরি হচ্ছে থ্রম্বাস অ্যান্ড দ্যাট ইজ গোয়িং টু এন্ড। এটা বেশি পাওয়া যায় এট্রিয়াল ফিব্রিলেশনে বিকজ অফ চেঞ্জড রিওলজি। তুমি চিন্তা করো সাইনাসে কি হচ্ছে, প্রপার কন্ট্রাকশন, প্রপার রিল্যাক্সেশন ইন সাইনাস রিদম। এট্রিয়াল ফিব্রিলেশন ইজ দিস, দ্যাট যখনই রিওলজি চেঞ্জ হচ্ছে, দ্য প্রপার্টি অফ দ্য লিকুইড প্রপার্টি, ফ্লুইড ডাইনামিক্স চেঞ্জ হচ্ছে, একটা জিনিস যেটা ওখানে লজড হয়েছিল দ্যাট উইল বি ডিসলজড। দ্যাট ইজ এগেইন এটা পরে কানেক্ট করতে হবে। সো থ্রম্বোটিক প্যাথোলজি, এম্বলিক প্যাথোলজি or maybe hemorrhagic pathology, ওখানেই blood vessel rupture করেছে in the internal capsule, in that particular side of the brain blood vessel has ruptured, so some stroke has happened. এই ঘটনা যদি ঘটে পেশেন্টের কি হবে? প্রবলেমটা এই দিকে, ইন্টারনাল কর্টেক্স থেকে পাথওয়ে নামছে, ইন্টারনাল ক্যাপসুলকে পাথওয়ে ইজ ক্রসিং, then it is coming down, going into the brainstem. In the medulla it is decussating. Clear? In the medulla, motor line, corticospinal tract. Corticospinal tracted 70-80% fibers will decussate at medulla and they will form the lateral corticospinal tract. আগের ছবিতে বোঝা যাচ্ছিল lateral corticospinal tract is responsible for distal movement. Distal মানে শুধু এইটা distal না, this is also distal, okay? Limb movement, distal movement. So what will happen? A already এদিকে ক্রস করছে, তাহলে লেফট সাইডে প্রবলেম হয়েছিল, মেডালা এদিকে ক্রস করে হাতে আর পায়ে যাচ্ছে। নাও দ্য প্রবলেম ইজ ইন দ্য লেফট সাইড ইন্টারনাল ক্যাপসুল, যে জায়গা দিয়ে এটা পাস করছিল, তা যদি হয় হোয়াট উইল হ্যাপেন? মুভমেন্ট অফ দিস সাইড উইল বি লেস, ডেফিশিয়েন্ট। ক্লিয়ার? তাহলে পেশেন্ট তোমার কাছে আসবে ইউনিল্যাটারাল উইকনেস। পেশেন্ট উইল কাম টু ইউ উইথ ইউনিল্যাটারাল উইকনেস, প্রবলেম মাথায়। ইউনিল্যাটারাল উইকনেস, প্রবলেম মাথাতে। ক্লিয়ার? প্রত্যেকে বুঝতে পারছো জিনিসটা? তুমি কি দেখবে? তোমার কাছে তো এইভাবে পেশেন্ট আসবে না যে ও মাই গড দিস ইজ দ্য ট্রান্সেকশন অফ মাই স্পাইনাল কর্ড, আই হ্যাভ ড্রন ইট টুডে। নো, হি উইল কাম উইথ সাম সিম্পটমস। তুমি কি, and you will see the bundle of symptoms. Patient will come to you with weakness, one limb, one lower limb, one upper limb. If this kind of thing is present, it is called hemiplegia or hemiparesis. Hemiplegia means half of the body is paralyzed, the other half is okay. Hemiplegia মানে complete paralysis, hemiparesis I mean partial paralysis or weakness. দুটোই সেম জিনিস। Hemiparesis or hemiplegia তে lesion is there on the opposite side in brain. Clear? Plegia means fully weak, paresis means partial weak. কিছুটা পারছে কিন্তু হচ্ছে না। What kind of lesion? Upper motor or lower motor? এই যে লিশনটা হচ্ছে, is it an upper motor lesion or lower motor lesion? কোথায় প্রবলেম হয়েছে? তাহলে সেটা কি? আপার মোটর লিশন। এইবারে তুমি কানেক্ট করো জাস্ট যেটা পড়িয়েছিলাম, কি কি সিম্পটম থাকবে, কি কি সাইন থাকবে? অল দি আপার মোটর নিউরন লিশন সাইন গুলো থাকবে। এন্ড হোয়াট আর দ্য সাইন্স? এই সাইডে প্রবলেম, প্যারাসিস। আর কি থাকবে? টোন ইনক্রিজড, রিফ্লেক্স এক্সাজারেটেড, প্লান্টার Babinski positive, that means upgoing plantar. আমরা প্লান্টারের ক্লাস করিয়েছি, মোস্ট অফ ইউ হ্যাভ অ্যাটেন্ডেড দ্যাট ক্লাস। আমার যা মনে রয়েছে, প্লান্টারে আমাদের এখানে কি পাচ্ছিলাম? আইদার ফ্লেক্সার পাচ্ছিলাম অথবা কিছু পাচ্ছিলাম না। ইফ ইউ রিমেম্বার, মনে আছে তো প্লান্টারে কি পাচ্ছিলাম? যে এই যে গ্রেড টো আইদার ফ্লেক্সিং অর নাথিং। এদের ক্ষেত্রে কি হবে? গ্রেড টো উইল গো ব্যাকওয়ার্ড, এক্সটেনসর রিফ্লেক্স। দিস ইজ ওই মাথায় গেছে। আর কি হতে পারে? ক্লোনাস মে বি প্রেজেন্ট। আগের দিন বলেছি আপার মোটর নিউরন লিশন, ক্লোনাস মে বি প্রেজেন্ট, নট ইন অল কেসেস বাট মে বি প্রেজেন্ট। What will happen to the tone increase? What will happen to the power? Reduced. Power reduced. What will happen to the muscle bulk? Partial atrophy. প্রচন্ড বেশি অ্যাট্রফি হবে না। ক্লিয়ার এভরিবডি? ক্লিয়ার? এইবারে কামিং টু দি সেকেন্ড পজিশন, দ্যাট ইজ সাপোজ spinal cord, a particular segment of spinal cord is destroyed. Up above it, okay. Below it, okay. What will happen? What are the things that those are passing through the spinal cord? Crossed corticospinal tract passing through. Clear everybody? কি যাচ্ছে এদিক থেকে এদিকে পাস করছে corticospinal tract. What else? Lateral spinothalamic passing through. Dorsal column passing through. Ipsilateral কারা তাহলে? স্পাইনাল কর্ডের থ্রু দিয়ে ইপসিল্যাটারাল কারা যাচ্ছে? ডরসাল যাচ্ছে, কর্টিকোস্পাইনাল ও ইপসিল্যাটারাল যাচ্ছে, কারণ ক্রসিং উপরে হয়ে গেছে। স্পাইনাল কর্ডে কন্ট্রাল্যাটারাল কে হচ্ছে? স্পাইনোথ্যালামিক। স্পাইনোথ্যালামিক স্পাইনাল কর্ডে উপরে কি চেঞ্জ হয়ে গেছে দেখার দরকার নেই, দ্যাট ইজ ইনট্যাক্ট। আমার যা প্রবলেম হবে দু সাইড থেকেই যখন আসছে, উপরে কি হচ্ছে দেখার দরকার নেই, দ্যাট ইজ ইনট্যাক্ট। তাহলে যদি আমার স্পাইনাল কর্ডটা খারাপ হয়, দিস ইজ হোয়াট ইজ দিস? এটা কি প্রত্যেকে নামছে? কোন ট্র্যাক? এটা আরো উপরে ট্রেস করলে অ্যারো দেখো, অ্যারোটা দেখো, অ্যারোটা দেখো। হ্যাঁ, তো ইট ইজ অ্যারোটা কোন দিকে? ডাউনওয়ার্ড অর আপওয়ার্ড? Downward. If the arrow is downward, what does that signify? Motor. Motor. ডাউনওয়ার্ড অ্যারো মোটর, মাথায় ভাবছি হাতে কাজ হচ্ছে, দ্যাট ইজ মোটর। ক্লিয়ার? হ্যাঁ, তাহলে এখানে কি নামছে একটা যে স্ট্রেট লাইন যেটা আসছে দ্যাট ইজ কর্টিকো স্পাইনাল। ল্যাটারালটা এঁকেছি, অ্যান্টেরিয়ারটাও আঁকা যায়, ওই সাইড থেকে অ্যান্টেরিয়ারটাও আসছে বেসিক্যালি। সো এইটা কোথায় ডেকাসেট করছি? ইন দ্য মেডালা, তো উপরে। ওর কি হচ্ছে দেখার দরকার নেই আমার, কারণ দ্যাট এরিয়া ইজ ওকে। whatever will happen below the lesion or at the level of the lesion. স্পাইনাল কর্ড লিশনের মজা এটাই, যা হবে below the lesion or at the level of the lesion. Above the level everything is normal, কারণ ওখানে there has been nothing. Similarly, what is this dotted line? সেন্সরি কোনটা, অ্যান্টেরিয়ার না পস্টেরিয়ার, ভেন্ট্রাল না ডরসাল? ভালো কথা। তাহলে ডটেড লাইনটা যাচ্ছে, ক্লিয়ার? এটা কি ডরসাল কলাম, এখান থেকে কোন দিকে যাবে করে স্ট্রেট সেম ডিরেকশনে ইট উইল গো আপ। সো দিস ইজ ডরসাল কলাম, আই মিন posterior tract, ক্লিয়ার? কি নিয়ে যায়? ফাইন টাচ, স্টিরিওগনোসিস, ভাইব্রেশন এটসেট্রা। গেল। পেন অ্যান্ড টেম্পারেচার, পেন অ্যান্ড টেম্পারেচার কোথা দিয়ে যাবে? তাহলে যা আসবে এদিকেরটা এদিক দিয়ে যাচ্ছে, ক্লিয়ার? হয়ে উপরের দিকে চলে যাবে, করে কোথায় যাবে? থ্যালামাস। করে কোথায় যাবে? থ্যালামাস থেকে দ্য সেম ডিরেকশনে কর্টেক্স। হলো? কিন্তু দেয়ার ইজ আ চেঞ্জ। কোন জায়গাতে চেঞ্জ হচ্ছে? এই জায়গাতে চেঞ্জ হয়ে যাচ্ছে, এইখানে। এটা তাহলে এদিক থেকে আসছে, এসে স্পাইনাল কর্ডের মধ্যেই ডেকাসেট করে ওদিক দিয়ে বেরিয়ে যাচ্ছে। ক্লিয়ার হলো? ক্লিয়ার হয়ে গেল? সিমিলারলি আদার সাইডেও সেম সিচুয়েশন। কর্টিকোস্পাইনাল আছে, এদিক থেকে স্পাইনোথ্যালামিক আসছে, আর নিচ থেকে ডরসাল ট্র্যাক্ট যাচ্ছে। বোথ সাইড সেম। ক্লিয়ার এভরিবডি? বোথ সাইড সেম। এটাকে যদি একটু ডিফিকাল্ট হবে পিকচারটা, যদি আমি এখান থেকে নিই, এটা এদিকে গিয়ে এই যাবে, এটা হচ্ছে পেনেরটা, ডরসালটা এদিক থেকে গিয়ে এই যাবে, আর উপর থেকে যে ট্র্যাক্ট আসছে তোমার আমাদের কর্টিকোস্পাইনাল, সে এইখান থেকে গিয়ে এই যাবে। ক্লিয়ার এভরিবডি? এই দুদিকের ইট ইজ ক্লামজি, বাট দুদিকের যখন আমরা আসছি তখন জিনিসটা তাই। দুটো জিনিস করাবো যেটা স্পাইনাল ট্র্যাক্টের রয়েছে। কমপ্লিট ট্রানজ্যাকশন, পুরোটা কেটে গেছে, পুরো কেটে গেছে, পুরোটা ড্যামেজড। হোয়াট উইল হ্যাপেন? কমপ্লিট ট্রানজ্যাকশন অফ স্পাইনাল কর্ড, হোয়াট উইল হ্যাপেন? ওই লেভেলের নিচে এফেক্ট পাবো, ওই লেভেলের উপরে এফেক্ট পাবো না, ওই লেভেলেও এফেক্ট পাবো। ক্লিয়ার এভরিবডি? ওই লেভেলের নিচে কি এফেক্ট পাবো? যেতে পারবে না। ওই সাইডের নাও, দু সাইডেরই, এটা পুরো গেছে। পেন টেম্পারেচার যাবে না। হোয়াট উইল হ্যাপেন টু দি অটোনমিক? অটোনমিকও খারাপ হয়ে যাবে, কিছুই যাবে না নিচে, বেসিক্যালি কিচ্ছু যাবে না, ইজি। কিন্তু কি পাবে সেখানে? আগেরটায় স্ট্রোকে কি পেয়েছিলে? এই প্রবলেম। এবারে কি পাবে? এই প্রবলেম। উপর ঠিক আছে, ক্লিয়ার হলো? সো দিস ইজ নোন অ্যাজ প্যারাপ্লেজিয়া অর প্যারাপেরেসিস। হেমিপ্লেজিয়া, প্যারাপ্লেজিয়ার ডিফারেন্স। তাহলে বিলো দ্য লিশন অ্যান্ড অ্যাট দি লেভেল অফ দ্য লিশন কি কি জিনিস চলে গেল? মোটর ট্র্যাক্ট গান, sensory tract from both side gun, autonomic supply gun. So the patient will be having paraplegia with sensory deficit with bladder bowel deficit. Autonomic গেছে তো, paraplegia, sensory deficit, bladder bowel deficit পুরো চলে যাবে। তো ইউজুয়ালি এই পেশেন্টগুলো যেটা হয়, পা দুটোই নাড়াতে পারছে না, মুভমেন্ট গান, সেন্সেশন চলে গেছে, রিফ্লেক্সেস আর গান, এবং you will be having autonomic bladder deficit. অনেক সময় autonomic other changes ও থাকে, কারণ মেজর পার্টের ইয়ে চলে গেছে, তোমার autonomic supply চলে গেছে। So BP may be fluctuating, usually BP can fall down, কারণ কি adrenergic যে রেসপন্সটা থাকে, the vasoconstriction that has gone. So একটা মেজর পার্টের vasoconstriction, if it is gone, total peripheral resistance will come down, afterload will come down, usually 40 to 50 millimeter drop in BP happens. Bladder bowel not functioning properly, they will most likely be having atonic bladder, মানে ওই জন্য দেখবে এই পেশেন্টগুলোর ক্যাথেটার করে দিতে হয়, and there are certain steps or certain stages of this kind of condition. When a complete transaction happens, total all the spinal cord pathways are destroyed or damaged, we call it spinal shock. এই স্পাইনাল শকের কয়েকটা স্টেজ আছে। ইনিশিয়াল স্টেজ হচ্ছে অ্যারিফ্লেক্সিয়া, সো spinal shock when the whole transaction is happening, anything below is not functional. Clear? This is spinal shock on both sides because whole spinal cord at that segment has been gone. So there are certain stage, initial 0 to 24 hours, we have areflexia or hyporeflexia. So totally all the reflexes are gone. তারপরে যেটা দেখতে পাওয়া যায় টু সাম এক্সটেন্ট অল্প অল্প করে ইনিশিয়েশন অফ রিফ্লেক্স অ্যাক্টিভিটি, এবং একটা টাইম আসে যখন অ্যাবারেন্ট রিফ্লেক্স অ্যাক্টিভিটি অর মাস রিফ্লেক্স ইজ সিন। পুরো জিনিসটাকে যদি আমরা বলি, সো দেয়ার আর সার্টেন থিংস 0 to 24 hours areflexia, 1 to 3 days return or initiation of reflex activity, return or initial return of reflex activity, 4 days to 1 month, these are the stages of spinal shock, 4 days to 1 month hyperreflexia, 4 days to 1 month hyperreflexia, 1 month to 12 months variable recovery, 1 month to 12 months variable recovery. ব্যাপারটা কিছুই না, যে কোনো ইনজুরি হলে তারপর দেয়ার উইল বি উন্ড হিলিং। এখানেও সে জিনিসটা হচ্ছে ইনিশিয়ালি অল রিফ্লেক্সেস গান, মানে লোয়ার মোটর নিউরন ইজ টোটালি সুইচড অফ। তারপরে পার্শিয়ালি তোমার নতুন ডিনার্ভেশন হাইপার সেন্সিটিভিটি হয়। উই শুড হ্যাভ আ সেপারেট ডিসকাশন ফর দিস বিকজ ইট ইজ গোয়িং টু ডিপ। So denervation hypersensitivity হওয়ার জন্য, if you remember what that is, I don't know whether you remember what is denervation hypersensitivity. To some extent neural pathways reverberates and returns back to or tries to return back to normalcy. So initially some reflexes are seen. এরপরে যেটা হয়, the problem in this segment that is behaving as an upper motor neuron, so anything below তারা একটু upper motor neuron টাইপের দেখায়। So that is known as the hyperreflexia, 3 নম্বরে hyperreflexia হচ্ছে। And the fourth, recovery takes approximately a year or so. Variable recovery সবার হবে কিনা we even don't know. So this is the overall features of the spinal shock. 4টে স্টেজ আছে। আমাদের টাইম কম, দরকার হলে পরে আরেকদিন এখান থেকে আরো ইলাবোরেট করব। আরেকটা ইম্পর্টেন্ট জিনিস বলে we need to get into vestibular apparatus. Now think of this scenario because it requires, I think কোনো ইয়েতে আমাদের পড়িয়ে দিতে হবে এই জায়গাটা আরেকটু, if you have any issue regarding this. Okay, now think of a scenario where hemisection of spinal cord has happened. Hemisection of spinal cord has happened. Hemisection, অর্ধেক স্পাইনাল কর্ড চলে গেছে। You tell me what is happening then? ওদিকে ডর্সাল কলাম চলে যাবে, উল্টো দিকের স্পাইনোথ্যালামিক ট্র্যাক্ট চলে যাবে, আর উপর থেকে আসা ইপসিল্যাটারাল কর্টিকোস্পাইনাল ট্র্যাক্টের কোনো এফেক্ট থাকবে না ওই দিকে। ক্লিয়ার হয়ে গেল? ইপসিল্যাটারাল কর্টিকোস্পাইনাল ট্র্যাক্টের কোনো এফেক্ট থাকবে না। ক্লিয়ার? কি কি হচ্ছে আবার তাহলে বলো? কেন থাকবে না? কেটে যাচ্ছে তো। এখান দিয়ে কি কি নামছে? মোটর ট্র্যাক্ট। মোটরটা কোন দিকে যাচ্ছে? হাতে 5টা আঙ্গুল থাকে, আমি কমিয়ে ফেলেছিলাম। 6টা করলে রোশন হয়ে যাবে, যাই হোক হতেই পারে, যাকে। সো এই দিকটা গেছে, রাইট সাইড গেছে, রাইট হ্যান্ড দিয়ে ব্যাপারটাকে বলছি, রাইট সাইড গেছে। এদিকে যেটা ট্র্যাকটা আসছে, মাথায় কি ডেটা সেট হয়েছে ভাবার দরকার নেই। আমার রাইট সাইডে যে হাতের ট্র্যাকটা আছে সে তো রাইটের স্পাইনাল কর্ড দিয়ে পাস করছে, এই জিনিসটা তো ক্লিয়ার। সেটা কাজ করাচ্ছে লেফট হেমিস্ফিয়ার থেকে, ওইটাই কনফিউজ হলো না। ক্লিয়ার এভরিবডি? রাইটে যেটা আসছে সেটা তো যে সিটি লেভেলে, সার্ভাইকোথোরাসিক লেভেলে, রাইট সাইড দিয়েই তো পাস করছে স্পাইনাল কর্ড। তাহলে রাইট মোটর ট্র্যাক্ট খারাপ হয়ে গেছে, তাহলে রাইট হ্যান্ডে কিছু অ্যাকশন থাকবে না, রাইট হ্যান্ডে প্যারালাইসিস থাকবে যদি রাইট সাইডের স্পাইনাল কর্ডে হেমিসেকশন হয়। ক্লিয়ার এভরিবডি? ডোন্ট গেট কনফিউজ, এই রাইট সাইড ইজ সার্ভড বাই দি লেফট হেমিস্ফিয়ার। এটা ক্লিয়ার, মানে পরীক্ষা কোশ্চেনই আসছে না এখানে, ওর মাথায় কি হচ্ছে দেখার দরকার নেই, দ্যাট ইজ ইনট্যাক্ট। ডোন্ট গেট কনফিউজ, অনেকে ওই জন্য ইপসিলেটারালে কনফিউজড হচ্ছে। দ্য প্রবলেম ইজ হিয়ার, রাইট সাইড, তাহলে রাইট হ্যান্ড গেছে, দিস ইজ অ্যান ইপসিলেটারাল প্যাথোলজি, নট কন্ট্রালেটারাল প্যাথোলজি। এটা কন্ট্রালেটারাল প্যাথোলজি only will happen when we are considering the brain. We are not considering the brain to spinal cord things were perfect, আমরা কনসিডার কেন করতে যাব? ক্লিয়ার? রাইট সাইড দিয়ে যেটা আসছে রাইট ইয়েতে গেল, তাহলে রাইট সাইডের ল্যাটারাল কর্টিকোস্পাইনাল ট্র্যাক্ট গান, তাহলে রাইট সাইডের লিম্বে মোটর ফাংশন গান। ক্লিয়ার? প্যাথোলজি ইন দি রাইট হাফ of the spinal cord. So this is an ipsilateral motor loss. Clear everybody? Ipsilateral motor loss. What will happen to the dorsal tract? এখান থেকে যেটা dorsal দিয়ে যাচ্ছে কাজ করবে কি করবে না? করবে না। So ipsilateral dorsal tract loss. তাহলে কি কি আসছে? Ipsilateral motor action, ipsilateral dorsal. Clear? What will happen to pain and temperature? Spinothalamic. কে পাস করছে এখান দিয়ে স্পাইনোথ্যালামিকে? কোন সাইড থেকে? এই সাইড থেকে। লেফট হ্যান্ড থেকে যে স্পাইনোথ্যালামিক, সে এইখানে, এই জায়গাটা তো ঠিক ছিল, এ অবধি তো ঠিক আছে, এ অবধি ঠিক আছে, লেফট হ্যান্ড থেকে যে যাচ্ছে ঠিক আছে, সে এখানে যাওয়ার পরে তার প্রবলেম হয়ে গেছে। ক্লিয়ার হলো? তাহলে কে গেল? স্পাইনোথ্যালামিক। হ্যাঁ, কোন সাইড থেকে? Contralateral. So contralateral spinothalamic. পেশেন্ট কি নিয়ে প্রেজেন্ট করবে? সো অপোজিট সাইডের পেন টেম্পারেচার পাচ্ছে না, রাইট সাইডের পলসি, এই সাইডের পাটা ঠিক মতো কাজ করছে না, সেন্সেশনও নেই, ভাইব্রেশন সেন্স চলে গেছে, জয়েন্ট পজিশন সেন্স চলে গেছে ফ্রম দিস সাইড, বাট পিন প্রিক করো, ওরে বাবা লাফিয়ে উঠছে, পেন রয়েছে। এই সাইড পারফেক্ট, পিন প্রিক করো, কিছু বুঝছে না। গট ইট? দিস ওয়ে উই ডিফারেন্সিয়েট। পেশেন্ট তো আসবে না এই ছবি নিয়ে, পেশেন্ট আসবে না। পেশেন্ট কিরকম আসবে? এই সাইডে পিন প্রিকটা বুঝছে না, কিন্তু এই সাইডের রিফ্লেক্স ঠিক আছে, এই সাইডের মুভমেন্ট ঠিক আছে, এই সাইডের জয়েন্ট পজিশন ঠিক আছে, এই সাইডে পিন প্রিক বুঝছে, কিন্তু এই সাইডের জয়েন্ট পজিশন ঠিক নেই, এই সাইডের মোটর ফাংশন ঠিক নেই। সো দিস ইজ দ্য ফিচার অফ হেমিসেকশন অফ স্পাইনাল কর্ড। হেমিসেকশন মানে পার্শিয়াল, একটা হাফ স্পাইনাল কর্ডে চলে গেছে। Sometimes we get classical hemisection, sometimes we get a little atypical hemisection, যেখানে দেখবে কিছু চলে গেছে কিছু সাইডে, কিছু নেই। As you progress in the career, you will find a number of atypical cases, but basic, first you need to know the typical case, and this is known as Brown-Sequard syndrome. এই জিনিসটা যেটা হয়েছে পরীক্ষার হেমিসেকশন অফ স্পাইনাল কর্ড, শর্ট নোটের জন্য রেডি থাকবে। ছবিটা দেবে, দিয়ে ইপসিল্যাটারাল মোটর, ইপসিল্যাটারাল ডরসাল কলাম, কন্ট্রাল্যাটারাল স্পাইনোথ্যালামিক, প্রত্যেকটা কি কি নিয়ে যায় সেইভাবে ডেফিসিয়েন্ট হবে। ক্লিয়ার এভরিবডি? দিস ক্যান হ্যাপেন ডিউ টু এনি স্পাইনাল কর্ড প্যাথোলজি। কি প্যাথোলজি রাইট নাও ইউ ডোন্ট হ্যাভ টু রিমেম্বার, হ্যাঁ, ট্রমা হতে পারে, হোয়াট এভার, কিন্তু দ্য ফাংশন যেটা লাস্টে হচ্ছে দ্যাট ইজ ব্রাউন-সেকার্ড সিন্ড্রোম। আমাদেরকে ভেস্টিবুলার অ্যাপারেটাস স্টার্ট করে দিতে হবে, উই ডোন্ট হ্যাভ টাইম। So vestibular apparatus, this is one of the most complex thing in your study. আমি জানি না, যদি না হয় পরের দিন আমরা এটাকে করব। মোস্ট কমপ্লেক্স থিং ভেস্টিবুলার অ্যাপারেটাস। ফার্স্ট অফ অল, পড়ানো হয়েছে কি ভেস্টিবুলার অ্যাপারেটাস? হয়নি তো? দিস ইজ দ্য ক্লাস ফর দ্যাট দেন। ওকে, ভেস্টিবুলার অ্যাপারেটাসটা, হোয়াট ইজ দ্যাট? হোয়াট ইজ দ্য ভেস্টিবুলার অ্যাপারেটাস বাই দি ওয়ে? কোথায় থাকে? ইনার ইয়ারে থাকে। সো বেসিক্যালি কেন দরকার ভেস্টিবিউলার অ্যাপারেটাস? ব্যালেন্স। ওকে, আর এই যে ধরো তোমরা 9টার ক্লাসের 9:15 ঢোকো, আমি দেখি, তারপরে এরকম করে হেঁটে ওই পিছনে চলে যায়, যতক্ষণ যায় ইমেজটা আমার চোখে একদম ক্লিয়ার থাকে। কি করে পসিবল? ও তো এরকম কাঁপতে পারতো সেই ভিডিও কনফারেন্সিং এ যেরকম হয়, কিন্তু ইমেজ একদম পারফেক্ট ইমেজ থাকে। কি করে পসিবল? তুমি দাঁড়িয়ে আছো, একটা মারুতি 800 পাস করছে, এখান দিয়ে পাস করছে, এখান দিয়ে যেতে যেতে কি মারুতি 900 হয়ে যায়? হয় না, ইট স্টিল রিমেইনস মারুতি 800। কি করে পসিবল? আমরা কি করছি? এটা চোখে দেখছি, চোখে ম্যাক্সিমাম রেজলিউশনে কখন দেখতে পারবো? যখন ইমেজ ফোভিয়া সেন্ট্রালিসে আসবে। ক্লিয়ার এভরিবডি? যেখানে ম্যাক্সিমাম কোনসেল কনসেন্ট্রেশন আছে, কোনসেল কনসেন্ট্রেশন আছে। তাহলে গাড়িটা যদি মুভ করে এই পজিশনে, ইফ দ্য কার ইজ হিয়ার ইন দ্য ফোভিয়া সেন্ট্রালিস, যখন মুভ করছে তখনও তো আমাকে ফোভিয়া সেন্ট্রালিসে গাড়িটার ইমেজ রাখতে হবে। দিস ইজ ওয়ান অ্যাসপেক্ট। সেকেন্ড অ্যাসপেক্ট, তুমি এদিকে রয়েছো, তুমি হাঁটছো বা তুমি হাঁটছো, একটা বিলবোর্ডে কিছু লেখা আছে, সাইন বোর্ডে লেখা শান্তিনিকেতন মেডিকেল কলেজ লেখা আছে, তুমি হেঁটে যাচ্ছ, এরকম করতে করতে তোমার পজিশন চেঞ্জ হচ্ছে, শান্তিনিকেতন মেডিকেল কলেজ কিন্তু জল জল করছে। কি করে পসিবল? ভেস্টিবিউলার অ্যাপারেটাস। ক্লিয়ার? নইলে কি? কারণ কি, আমি যখন এইখানে দাঁড়িয়ে তখন ফোভিয়াতে একটা ইমেজ হলো, আমি যখন মুভ করছি তখনও ফোভিয়াতে সেম ইমেজ পারসিস্ট করছে, সেম রেজলিউশনে ইমেজ পারসিস্ট করছে। কি করে পসিবল? ভেস্টিবিউলার অ্যাপারেটাস। দিস হ্যাজ আ নেম, ভেস্টিবিউলো অকিউলার রিফ্লেক্স, VOR। দুটো রিফ্লেক্স হয় ভেস্টিবিউলার অ্যাপারেটাসের থ্রু দিয়ে, যেটা তোমাদের জন্য ইম্পর্টেন্ট। ওয়ান ইজ ভেস্টিবিউলো অকিউলার রিফ্লেক্স, দি আদার ইজ ভেস্টিবিউলো স্পাইনাল রিফ্লেক্স। ভেস্টিবিউলো অকিউলার রিফ্লেক্স হচ্ছে মুভমেন্ট অফ হেড বাট স্টিল ফিক্সেটিং দি ভিশন, দ্যাট ইজ ভেস্টিবিউলো অকিউলার রিফ্লেক্স। এদিকে ঘুরে ক্যামেরাটা যেমন দেখছি, এদিকে ঘুরেও ক্যামেরাটা সেরকম দেখতে পারি। and you can see যখন আমার হেড এই দিকে যাচ্ছে, আইজ ওই দিকে যাচ্ছে, ইটস অপোজিট ডিরেকশন। এন্ড যতটুকু দরকার ততটুকু, তুমি ক্যামেরার দিকে তাকিয়ে এদিকে ঘুরে ক্যামেরা দেখতে গেলেও আইজটাকে ততটাই যেতে হবে যতটা হেড এই দিকে গেছে। ক্লিয়ার? সো করেসপন্ডিং অ্যাঙ্গেল in the opposite direction, eyes movement and head movement, that is vestibulo-ocular reflex. কেউ বলে দিচ্ছেন I am not measuring, হ্যাঁ 25 ডিগ্রি এদিকে যাব, আইসটাকে 25 মুভ করতে হবে। It's happening unconsciously, so it is a reflex pathway, and since it is a reflex pathway, it will follow the rule of the reflexes, মানে একটা অ্যাফারেন্ট থাকছে, একটা সেল বডি থাকছে, একটা ইফারেন্ট থাকছে, প্রসেসর অর্গান থাকছে, and এন্ড অর্গান থাকছে। This is the whole process. ক্লিয়ার? এটা হচ্ছে ভেস্টিবিউলো-অকিউলার রিফ্লেক্স। The second one is the vestibulospinal reflex. মাথা নামাচ্ছ, এই করছো, বডিটার বিভিন্ন দিকে মুভ হচ্ছে। Actually what is happening, your vestibular nucleus in body, in the brain কোথায় থাকছে? ব্রেন স্টেমে থাকছে, that's the eighth nerve nucleus. It is finding out the difference in CG, difference in body position, and appropriate muscles, extensor or flexor muscles are contracted and then your position is maintained. This is vestibulospinal reflex. কিসের থ্রু দিয়ে হচ্ছে? ডরসাল কলাম দিয়ে ভেস্টিবিউলারে যাচ্ছে, ভেস্টিবিউলার থেকে কর্টিকোস্পাইনাল দিয়ে সেই পার্টিকুলার মাসলটাকে ট্রাঙ্ক মাসলটাকে ধরে রাখছে। মোস্ট অফ দ্য টাইম দিস ইজ আ কনজুগেট মুভমেন্ট বিটুইন দি অ্যান্টেরিয়র কর্টিকোস্পাইনাল অ্যান্ড ল্যাটারাল কর্টিকোস্পাইনাল, মানে মোটর ট্র্যাকটাকে ইয়ে করছে। কানেকশনটা বোঝার চেষ্টা করো, আমি যে বডি মুভ করছি এই মুভমেন্টে পড়ে যাচ্ছি না, বিকজ অফ দি ভেস্টিবিউলোস্পাইনাল রিফ্লেক্স। এই মুভ করলে কি হচ্ছে? some other muscles they have to be contracted, otherwise what will happen? My CG is here but something is compensating my posture. What is compensating my posture? 3-4 things are there, but most important one is the vestibulospinal reflex. What is that? Your sensory system is coming and reaching to the vestibular nerve and vestibular nucleus. They are sending to the appropriate spinal segment motor, and that appropriate spinal segment motor is contracting the appropriate muscle. এদিকে ঘুরলে হয়তো এদিকের মাসলকে একটু টাইট রাখতে হয়, আদারওয়াইজ এক্সটেনসর মাসলগুলো টাইট রাখতে হবে, আদারওয়াইজ you will fall down. Understood? So this is vestibulospinal reflex. Two types: vestibulo-ocular reflex, vestibulospinal reflex. Now coming to the vestibular apparatus, one of the most difficult area. So কোথায় থাকে vestibular apparatus? Inner ear. Anatomical location. Temporal bone. In between that, it is present. কিরকম দেখতে? সেমিসার কি কি অপশন আছে? তিনটে সেমিসার্কুলার ক্যানাল আছে, দুটো অটোলিথিক অর্গান রয়েছে। 3 semicircular canal, 2 otolithic organ. With my limited drawing capacity, I am trying to draw right now. Okay, এটা easiest. আমার মতো যারা আছে লিমিটেড ড্রয়িং ক্যাপাসিটি, তাদের জন্য দিস ইজ দ্য ইজিয়েস্ট ওয়ান, যে ওয়েতে করছি। সো তিনটে সেমিসার্কুলার ক্যানালকে we can, this is one vertical, this is one horizontal, and this is another oblique. তিনটে semicircular canal রয়েছে, vertical, horizontal, oblique. Then we have টু অর্গানস, একটা এখানে একটা এখানে, দুটো অর্গান রয়েছে। এই জায়গাটায় আমাদের যেমন সেই অর্গান অফ কর্টি অ্যান্ড স্টাফ যা আছে আছে থাক। The lower part of each semicircular canal that is thickened, that is swollen, and this is known as ampulla. Semicircular canal এর যে lower part গুলো রয়েছে, those are known as ampulla. Here we have a horizontal organ, here we have a vertical organ. These are the otolithic organ. Horizontal organ, the upper one is known as utricle, and the vertical one, lower one, is known as saccule. These are otolithic organ because carbonate crystals are present. The otoliths are present. These are the ear rocks. Choto solid particles are present in the gel-like structure which is present over there. Clear? Otolithic organ. Tale. Now to make it a little, and make it like this. পুরোটা যাতে দেখতে ভালো লাগে, ক্যানাল গুলোকে পরিষ্কার তুমি বুঝতে পারছো, so it will make it a little like this. So these are the tubes. Clear? এইবারে basic idea you need to identify. Semicircular canal. If we have a cross section of semicircular canal, it will look like this. Okay? And in this, you will be having a membrane. এর মধ্যে একটা মেমব্রেন পাচ্ছ, which is পুরোটার একটা মেমব্রেন থাকছে। ওকে, সো এটা হচ্ছে বেসিক আইডিয়া অফ দি সেমিসার্কুলার ক্যানাল। তার ক্রস সেকশন করলাম, কয়েকটা খুব ইম্পর্টেন্ট জিনিসের মধ্যে রয়েছে দ্যাট ইউ নিড টু আন্ডারস্ট্যান্ড। Semicircular canal is not an otolithic organ, so you are not having the ear rocks or carbonate crystals inside them. What we have hair cells. এগুলো হচ্ছে hair cells. Hair cells are nothing but modified cilia. You can see এই যে cilia গুলো আঁকছি, এর মধ্যে some cilia are shorter, some cilia is longer. যে longest cilia is known as kinocilium. Longest cilia is known as kinocilium. Group of cilia are known as stereocilium. So this is kinocilium and stereocilium, and that helps in restoration of balance. I am coming to that. এবারে cilia গুলোর উপরে if you look at, if it is at all visible from that side, there is a blue color, একটা blue কালারের একটা পোরশন এঁকেছি, and this is the gel structure, cupula বলে এটাকে. So this is the gel structure which is present on the hair cells. This is the gel-like structure যেটা hair cells এর উপরে present থাকছে। Gel. Clear? Next coming thing, you can see a membrane. Inside membrane a different fluid, outside membrane a different fluid. এই যে মেমব্রেনটা আছে, আউটসাইড মেমব্রেন যে ফ্লুইডটা আছে, This is known as perilymph. Extracellular fluid. এটা almost plasmar ultrafiltrate. Perilymph. Inside membrane যে fluidটা আছে, this is known as endolymph, and it is slightly different. It is slightly different. Endolymph. Okay. Endolymphe যেটা দেখা যায় যে potassium concentration is much higher, more viscous এবং different from the perilymph, and it has a connection with the cupular mechanism and the hair cell. এই অবধি প্রত্যেকের ক্লিয়ার তো? পুরো জিনিসটা ক্লিয়ার হয়ে গেছে। আরেকটা জিনিস ক্লিয়ার তো, জেল has a different viscosity than water or extracellular fluid or plasma. This is clear. তাহলে একটা বটলের মধ্যে if we keep some gel and some water, and if we move the bottle, gel and water will move in a different direction and with different velocity. Clear এই জিনিসটা? Because gel has a different inertia, water has a different inertia. Bottle যখনই মুভ করা শুরু করব, water will immediately start going downwards, gel will take some time because the consistency of this fluid is different. Clear? And this helps over here. Clear? এইবারে সিলিয়ার নিচে দিস ইজ দি সেল বডি, সিলিয়াগুলোর, এবং সেখান থেকে উই আর হ্যাভিং নার্ভস, নার্ভ ফাইবার। কোথায় যাচ্ছে? আলটিমেটলি দিস নার্ভ ফাইবারস আর ক্রিয়েটিং 8 নার্ভ, এটাই ভেস্টিবিউলার নার্ভ তৈরি করছে। সেল বডিগুলো থেকে নার্ভ যাচ্ছে, and when they are joining together they are creating the vestibular nerve. Clear? Vestibular nerve কোথায় যাচ্ছে? Vestibular nucleus. Where it is present? Vestibular nucleus is present in the brain stem. Where in the brain stem? Pons medulla junction, pondomedullary junction. Brain stem এ vestibular nucleus রয়েছে। Clear এই অবধি? So once again, this is the vestibular apparatus in simplified form. It has 3 semicircular canals. Semicircular canals are responsible to identify angular acceleration and deceleration. Angular acceleration and deceleration. 3 semicircular canals, each in a different plane. একটা vertical, so it helps in understanding this acceleration and this deceleration. একটা horizontal, so it helps in understanding this acceleration and this deceleration. আর একটা perpendicular to this z axis, xy axis এর সাথে z axis এ রয়েছে, so this helps in this. Clear? তিনটে সাইডে বোঝার জন্য হচ্ছে। এবারে তুমি বলতে পারো এই প্লেনগুলো ছাড়াও তো আমি করতে পারি, দিস ইজ আ ডিফারেন্ট, তিনটে প্লেন মিলিয়ে করছি, তো তিনটের প্রপোর্শনাল মুভমেন্ট হবে, তিনটে থেকেই অ্যাকশন পোটেনশিয়াল জেনারেট হবে অ্যান্ড দ্য রেজাল্টেন্ট মুভমেন্ট হবে। ক্লিয়ার? বোথ সাইডেই এই জিনিসটা ঘটছে। তাহলে ফার্স্ট লাইনটা ক্লিয়ার হয়ে গেল। সেকেন্ড, হোয়াট অ্যাবাউট দ্য হরাইজন্টাল ভেলোসিটি অর ভার্টিক্যাল ভেলোসিটি? এটা কি হেড মুভমেন্টটাকে বোঝে হচ্ছে সেমি সার্কুলার ক্যানেল। কিন্তু ধরো ইফ ইউ আর ইন আ কার এন্ড দ্য কার মুভিং ফার্স্ট, তোমার বডিটা ফার্স্টে এরকম পিছনে থাকলো, পিছন থেকে সামনে এলো, আবার ব্যাক করলো, এই যে কার মুভমেন্ট করছে, অর সাপোজ ইন আ লিফট, এলিভেটর, পুরো বডির উপরে যাচ্ছে, পুরো বডি নামছে। So this horizontal, pure horizontal and pure vertical movement is sensed by utricle and saccule. সেটার জন্য ওই সিস্টেমটা করা হয়েছে। This is such a complex system. If I can't finish it, we will continue in the next class. It is a very complex system basically. So utricle and বই পড়লে মনে হয় না কিছু বুঝবে, কোনো বই পড়ে আমিও কোনোদিন কিছু বুঝিনি এই জিনিসটা। It's a very complex, it's a 3-dimensional thing. Unless you understand this way, it's very difficult to understand actually. So উপরে যাচ্ছে বা গাড়িতে যাচ্ছ, তার জন্য হরাইজন্টাল বা ভার্টিক্যাল অ্যাক্সিলারেশন দ্যাট ইজ সেন্সড বাই ইউট্রিকল অ্যান্ড স্যাকিউল। What is the basic difference between utricle and what is the basic difference between otolithic organ, which is utricle and saccule, and the semicircular organ? The basic difference, first of all, pure horizontal and vertical. So straight line things are sensed by utricle and saccule. Angular and rotational things are sensed by semicircular canal. Secondarily, if we draw, আমি এই সাইডে স্যাকিউলটার একটা, স্যাকিউল বা ইউট্রিকল মোটামুটি একই, অ্যানাটমি প্রায় সেম, only thing the position is different, the organs are almost the same. So utricle and saccule, they are like this. Suppose this is এটা হচ্ছে বেসিক স্ট্রাকচার। যেটা হরাইজন্টাল আছে সেটা স্ট্রাকচার এই, যেটা ধরো ভার্টিক্যাল আছে সেটা স্ট্রাকচারটাও আঁকছি, বুঝতে সুবিধা হবে। এটা হরাইজন্টাল, এটা ধরো ভার্টিক্যাল। ক্লিয়ার হলো? দিস পিকচার ইজ নট কমপ্লিটলি পারফেক্ট। নীল দাগটা খাতায় আঁকার আগে একটু ওয়েট করো, আমি সেটা বলে দেবো তারপরে আঁকবে। নীল যে দাগটা এঁকেছি তার আগে একটু ওয়েট করো। ট্রাই টু আন্ডারস্ট্যান্ড what you are seeing. Cell, cilia, nerves going to the vestibular nerve. Cell, cilia, nerves going to the vestibular nerve. Gel like structure, blueটা হচ্ছে gel, clear? Endolymph type-এরই gel, almost same viscosity, blueটা gel. White গুলো হচ্ছে calcium carbonate crystals inside, যেগুলো হচ্ছে otolith, ear rock বলা হয়, ছোট crystal. Now you think this is horizontal, this is vertical. If you are standing like this, your horizontal organ is like this, vertical organ is like this. Same you, if you lie down, your horizontal will be vertical, your vertical will be horizontal. Clear? In between position, proportionate change in the position of this. Clear? তাহলে এই থাকছে, পুরো শুলে এই হয়ে যাচ্ছে, মাঝে থাকলে এরকম যে কোনো পজিশন হচ্ছে। And at this different position, জেলের শেপও ডিফারেন্ট হবে। At this different position, জেলগুলোর শেপটাও ডিফারেন্ট হবে। Try to understand. যদি বলা হয় why nature has provided us with otolith in otolithic organ and not in semicircular canal, তাহলে আমাদেরকে ফার্স্টে বুঝতে হবে what otoliths do. Otolith কি করছে? Otoliths solid তো, so they have some weight, some mass. তো যখন, now you will understand this. কেউ যার ভার্টিক্যালটা এরকম রয়েছে, ধরো ভার্টিক্যাল অর্গান, এভরিবডি ক্যান সি দ্য ভার্টিক্যাল অর্গান, মোটামুটি ম্যাক্সিমাম দেখতে পাচ্ছ। ভার্টিক্যাল অর্গানটা এরকম রয়েছে। অটোলিথ কি করবে? অটোলিথ গুলো নিচের দিকে আসবে। অটোলিথ আর সলিড, গ্র্যাভিটি, সো মোর অ্যান্ড মোর অটোলিথ উইল compress this. What will happen? Cilia will bend with the weight of the otolith, and this fluidটা কি হবে? ফ্লুইডও নিচের দিকে আসবে because of the gravity. So actual picture of this fluid will be a pear shaped, তাই না? অ্যাকচুয়ালটা তো এরকম হবে ফ্লুইডটা। তুমি যদি এবার বডিটাকে উপরের দিকে তোলো, ফ্লুইডটা আবার পজিশনটা চেঞ্জ করবে। The moment fluid changes the position, otolith will also move. Otolith will also budge on the cilia, and otolith will budge on the cilia. Ciliary movement will happen. Ciliary bending will happen. এই পুরো ভেস্টিবিউলার অ্যাপারেটাসে how things process. Whenever cilia bends, physical force developed. Physical force is conducted into depolarization. Depolarization causes the action potential in the nerve fibers. This action potential is taken via the vestibular nerve to the vestibular nucleus. That's the process. আবার বোঝার চেষ্টা করো, এই পুরো সিস্টেমের মধ্যে একটু আগে যে প্রশ্নটা করলাম যে অটোলিথ আছে কেন, কিন্তু ওখানে অটোলিথ নেই কেন? রিজন, মোস্ট লাইকলি রিজন ইজ তোমার এখানে অ্যাঙ্গুলার অ্যাক্সিলারেশনটা পাচ্ছ, and it is easy to move with angular acceleration. Otolithic organ are more for static, so ওই জন্য অ্যাক্সিলারেশনটা ওইভাবে পাচ্ছে না। নেচার হ্যাজ প্রোভাইডেড otoliths to make it more sensitive. আমি যদি একটু বেশি ওজনের কিছু দিই, তবে only gravity is acting over here. So that's why I have given certain extra particle to make the whole apparatus more sensitive in linear thing. In the angular thing, we don't require, because the thing is under gravity and under acceleration in various things or various direction. That's why otolith is not required in the SCC. Clear? আবার যাচ্ছি, whole systemটা কি করে কাজ করছে? Cilia bend হচ্ছে due to inertia, because যেদিকে মুভ করবে, first try to understand. Suppose this is the semicircular canal. You are moving your head to the right. The moment you are moving your head to the right, what will happen to the semicircular canal and the perilymph? It will move in this direction. মাথা যে মোমেন্টে রাইটে যাচ্ছে, সেমিসার্কুলার ক্যানাল আমরা হরাইজন্টাল আর ক্রস সেকশন এঁকেছি, দিস ইজ দ্য হরাইজন্টাল সেমিসার্কুলার ক্যানাল, ক্রস সেকশন এঁকেছি। মাথা যে মোমেন্টে রাইটে যাচ্ছে, হোয়াট ইজ হ্যাপেনিং? সেমিসার্কুলার ক্যানাল, রাইট সাইডে সেমিসার্কুলার ক্যানাল রাইটে যাচ্ছে। If you are moving your head on the right side, your right sided semicircular canal is also moving to the right side. Clear? But this endolymph has a different viscosity. That's why it is under a different inertia. So তোমার এটা যখন এদিকে মুভ করবে, এন্ডোলিম্ফটা অপোজিট দিকে মুভ করবে ডিউ টু দি ওয়েট অফ দি এন্ডোলিম্ফ, ডিউ টু দি ভিসকোসিটি অফ দি এন্ডোলিম্ফ। ক্লিয়ার এভরিবডি? এটা যখন রাইট সাইডে মুভ করছে, এন্ডোলিম্ফটা উল্টো দিকে মুভ করছে। The moment endolymph moves in the opposite direction, what will happen? Eighta semicircular canal is moving to this direction. Endolymph is either stationary or moving to the opposite direction. Initially, this endolymph will pressurize here, create the pressure on the cilia. The moment endolymph will create the pressure, কখন কি হচ্ছে? They will bend. Endolymphটা গিয়ে যদি hair cell, these are the hair cell, on it, if it creates the pressure, hair cell will bend. The picture will be this. When they will bend, the picture will be clear. It will bend, it will create a pressure, it will create a dislodgement. কোন দিকে বেন্ড করছে? Towards the gynoecilia or away from the gynoecilia? Towards the gynoecilia. খুব ইন্টারেস্টিং ভাবে জিনিসটা করা, যখন if the movement of endolymph is towards the gynoecilia, longest, tallest cilia, there will be depolarization. If it is away from the gynoecilia, there will be repolarization. Try to understand, যখন এই দিকটাতে রাইট সাইডে towards the gynoecilia মুভ করছে, সিমিলার অ্যাপারেটাস লেফট সাইডে away from the gynoecilia মুভ করবে, তাই না? সিমিলার সাইড লেফট সাইডে away from the gynoecilia মুভ করবে। So right side towards gynoecilia, left side away from the gynoecilia. Right side depolarization, left side repolarization. So right vestibular nerve depolarization action potential প্রচুর বেশি তৈরি হচ্ছে। Left ventricular nerve, vestibular nerve, we are having hyperpolarization. So সেখানে inhibition হচ্ছে। That's the idea so far. Clear? এই অবধি clear তো? Everybody understood? Huh?
We are here to cover this particular part of nose paranasal sinus. This is one of the important exam question area where we see these exam questions are teaching every time, and as well as this is one of the topic which is important for our clinical life as well. We see number of patients coming with this particular problem related to the nose paranasal sinus infections, etc., etc. It could be like the trauma which might be involving in this particular nose nasal region, because this is the part of the face which is projected, and this particular part is prone to have infection because of the exposure to this exterior, because this is the organ of respiration. So there are number of clinical variables are there related to this particular part, and as well as we see this particular clinical question based on this coming on testing your anatomy knowledge as well. So our point of concern today will be covering this particular nose. We'll be focusing on the skeleton of the nose, exterior of the nose, interior of the nose, nasal septum, how it is participating, how it is forming, the blood supply of the nose or interior of the nose, the nerve supply of it, which is related to this particular interior of the nose and as well as septum. Now then, once we have covered this part of the septum and all these nasal cavity, we will be moving to the expansions of the nasal cavity. We call them as paranasal expansion cavities. We call them as the sinuses, and the opening of the sinuses, if they are blocked, if this particular thing is clinically challenged in terms of infections, etc., etc., then we have to have this particular clinical problem based on this. So this is the point of concern. So first we cover the nose and the nasal cavity, then we move to this particular paranasal sinuses. So to start it, we have to understand this particular skeleton of the nose, which is constituting of partly cartilage, partly bone. So there are some external or extrinsic skeleton network is there, which this particular nose is forming. And as you know, this particular nose is an organ of respiration. We breathe in, breathe out. Along with that, inside to this particular nasal cavity, we have a cranial nerve place, which is the olfactions, which is the cranial nerve number 2. So which is organ of olfactions or smell is there. Along with that, this particular entry point of this air, which have got like functions, which is humidified or dehumidifying the air. What do you mean by the humidifying or dehumidifying? Now, depending on the environment, depending on the moisture we have there in our environment that is getting into this particular nasal cavity to the respiratory tract. Now, we need a particular pH or we need a particular amount of the oxygen, and as well as we need a particular amount of the moisture in it. So, if you have excess moisture exposed to this respiratory system, which is threatful, if it has a less moisture, which is also a troublesome thing. So, we have to have a proper balance, proper quotient of the moisture there. So if we are exposed to the dry environment, we have this particular nose and paranasal sinus which is secreting, making this particular air moist. And if it is exposed to the moist weather right now, what we are going through is a very humid and moist conditions. This particular nasal mucosa and this component within this particular nasal mucosa absorbs some amount of this particular moisture from the air and delivers the absorbed air or purified air to this particular respiratory system. Along with that, it takes the dust away, microdust which is present in the air, which is filtering it and letting it get into our respiratory system, the lungs, etc., etc. So these are the gross functions of this particular nose and nasal cavity and this particular the paranasal sinuses, etc., etc. Now, our concern is that we will be talking about this particular skeleton of the nose or exterior of the nose. So we have a skeleton of the nose which is made of the external bones or the exterior bones. So we have also mentioned this exterior or the external nose having two kind of skeleton element, which is made of bone, which is made of cartilages. So partly cartilage, partly bone, framing this entire network. There are number of bones which is forming it. There are number of cartilage which is forming here. So we have this particular bone related to the nose, which is known as nasal bone, which is present in the nose, which is framing it. Along with that, the projections and contributions, they are coming from the maxilla, frontal bone, nasal spine, they are contributing to it and forming this external skeleton of the nose. And along with that, we have the cartilages which is present. We call them as lateral cartilage, septal cartilage, which is forming this. But before we going into it, we have to understand different parts of the nose. The part of the nose which is related to the, attached to this particular forehead, we call them as a root. And whereas this particular downward most position, we call them as tip of the nose. And in between tip of the nose and the root of the nose, we have this body of the nose, we call them as dorsum. The projected side of the nose, we call them as ala of the nose. We are familiar with the word ala, which is looks like a wing, which has the nasal expansion, which is coming on the sides, which is known as ala of the nose. Now, if we go on the skeletal section, which is forming here, which I am mentioning, it is framed with this particular bone, which is forming the upper table of this nasal septum or upper table of this particular external nose. So this is the nasal bone which is making over here, right, left, and this particular bone is coming from this maxilla. So we call them as nasal part or frontal process of the maxilla which is coming over there. This is frontal bone which is going down and making this particular part. We call them the nasal part of the frontal bone making a union over there, and nasal spine which is present in this particular region. So this is a skeletal network made of bones over there. Then we go down in the lower part, which is made of partly cartilage, and we have contributions in between different types of cartilage. In the midline, we have a nasal septum. We have to learn a detail about the nasal septum, which is another cartilage which is hanging down. On this side, we have the lateral plates or lateral septal cartilage. Then we have the alar cartilage, which is making this particular different skeletal element of this particular nose or nasal cavity. Now you are getting into this particular important part for our understanding. We call them as nasal septum, which is splitting this nasal cavity into two halves, right half and the left half. Again, just like the exterior of the nose, the nasal septum is also partly bony, partly skeletal. The anterior part, just like the external nose, is made of cartilage. The posterior half of the nasal septum is made of this particular bone, and this part we have to understand the clinical problem. If you see this particular cross section picture, this is exposed with these nasal septum. We cannot see the lateral wall in this, and we have used different colors to project it to understand it better. As I have said, this anterior part of the nasal septum, which is blue in color, you are saying here, is made of the cartilage. We call them as septal cartilage. It is a single plate of cartilage. Now, this posterior part of the nasal septum is made of bone. There are two bones which are making contributions over there. One single piece of bone which is making this particular contribution from the septum on the posterior inferiorly, and on this posterior superiorly they have another bone which is making here, which is marked with the green line and this pink line. This particular bone which is making in the posterior inferiorly, we call them as vomer, which is resting on this particular palatine bone. So this particular vomer is making this particular region septum, which is below and above by this particular perpendicular plate of ethmoid. Now this particular perpendicular plate of ethmoid, you see that is continuous with this another plate of ethmoid. We call them as cribriform plate of ethmoid. Now this anatomy helps us to understand. Now through this cribriform plate of ethmoid, which is sieve, that means it's porous, we have this olfactory nerves runs from here and goes to the brain cavity. So over here is this cranial cavity which you are exposed to. Now if you are exposed to any kind of trauma or not trauma, if we have injury to this perpendicular plate of ethmoid, injuring these bony ends, if you have this particular thing exposed, that can rip and this injure the structure which is lying on top of it. So we'll be coming again when we are going to discuss some clinical problem regard to this particular cribriform plate of ethmoid and perpendicular plate of ethmoid. So this septum or septal cartilage architecture we have to know. Moving from here, this particular nasal cavity is exposed on having two kinds of opening. One is the anterior opening, one is posterior opening. Anterior nasal opening we can see, it's a visible part of this. If we throw light through this particular anterior nasal opening, we can see a part of this nasal cavity as well. The posterior nasal opening, normally we do not see. That part of the posterior nasal cavity or posterior nasal opening which is lying on the posterior side, this is the opening which you're seeing here. I'm marking over here. This opening we call them as choanae or posterior nasal opening. Through this opening, it enters to a space we call them as nasopharynx. We have seen number of features present on the nasopharynx, which is present on the lateral wall of the nasopharynx, which is opening of the eustachian tube, which is communicating with the middle ear, and as well as the folds, as well as the lymphoid aggregates, adenoids, etc., etc. Those parts we already have covered. So this particular anterior nasal opening and the posterior nasal opening both are important. Anterior one is accessible part, posterior one is non-accessible part. But yet in our clinical examination part, we have to see this posterior nasal opening. We cannot see that normally. Then we have to, if we have to see, we have to go for invasion. That means we have to invade some part. To see this particular posterior nasal opening, normally we do here, we do it by either by endoscopic process or using some kind of mirror. We call them as posterior nasal sinus or PNS mirror. We have a mirror which has fitted with this particular long string like this, stick like this, and then this mirror is placed to the oral cavity and placed over here. And if it is projected like submarine mirror which is projecting up, we can see this posterior nasal opening and the nasopharynx can be seen. This was the old way of seeing this with this PNS mirror. Nowadays we have the endoscopes to just like we can pass it through the nasal cavity or we can pass to the oral cavity and move it up, because this particular endoscopes, which is fiber optic, can be moved in different directions and can be seen. So these nasal openings, anterior and posterior nasal opening, clinically we do not call it posterior nasal opening. We call the word as choanae, C-H-O-N-A-E. That particular word is used in a clinical settings whenever we are exposed to it or whenever we recur to address that part. Now, coming to the other boundaries of the nasal cavity, it has a roof, it has a floor, it has a lateral wall and a medial wall. We'll be exposing one after another. It has a roof which you can see here, which is related to this particular base of the bone skull. That means it's related to the sphenoid bone. It is related to this particular ethmoid bone. We already have seen that perpendicular plate of ethmoid. In the front side, we have the frontal bone, which is related to it. It has a floor. It is resting on the hard palate, which is making this particular floor separating from the oral cavity. It has a septum, which is splitting it into two halves, anterior and right and left septum over there. We have the medial septum, which is exposing here. And it also has a lateral wall. So these features which is present on the lateral wall is or are our exam question. We have to understand this lateral wall well enough to understand the clinical problems. We understand these particular anatomical problems. Now, this lateral wall of the nose exposes this particular regions. We see this particular number of the bones which is hanging on lateral wall of the nose. How we can see this lateral wall of the nose? Only if you remove this particular nasal septum and cut it and split it and see it on the lateral wall, then it's visible. Beforehand, we have this particular picture where we have this particular nasal septum intact. So this is what we are seeing here before, the nasal septum in place. You crack this particular nasal septum, then we can see the lateral wall of the nose on the right side or the left side. So this is how we are seeing here. Within this particular lateral wall of the nose, we see there are kind of scroll-like bones which is overhanging. This scroll-like over, or kind of like a curved kind of bones which is hanging over here, we call this as concha. So this particular concas above and below, they are placed like this. There are three such bone placed over there. One is 1, 2, and 3. Out of this particular 3, the lowest one is kind of like a prominent one and the largest one. That's why whenever you are seeing that in a clinical setting, whenever we have split this and we are seeing this lateral wall of the nose, this one is obvious and visible very much. These two are brittle and small. Whenever we are making the section, this particular bone cracks. So many a times you may not see these particular bones whenever you are doing the anatomical sections, but they are there. So coming back to the lateral wall of the nose, that's what we're seeing here. On the lateral wall of the nose, we're seeing the three pieces of the bone. We call them as concas, and above below we call them as superior concha. Then we have the middle concha, and the largest of all is inferior concha. The superior concha and the middle concha is basically a part of ethmoidal bone which is projecting out, and inferior concha is a separate piece of bone and it can be separated out from rest of them. So this particular entity, you have to know what do you mean by the concha and how this particular thing is placed on the lateral wall of the nose above below. Now, if you have placed this particular entire thing on the lateral wall of the nose, this particular concha splits this particular lateral wall of the nose into some spaces. We call this as spaces as meatus. So under or above this particular concas, we have this particular spaces which is related to this particular lateral wall of the nose. We call them as meatus. So under or above this particular concus, the space, accordingly we name that superior meatus, inferior meatus, and middle meatus likewise. So this particular thing makes us clear about this particular meatus and this particular concus. So this is the superior meatus, this is the middle meatus, and this is the inferior meatus. The space under to it, this inferior concus, we call them as inferior meatus. The space between this middle concha and the space and inferior concha, we call them as middle meatus. The space which is lying between this middle concha and this particular superior concha, we call them as superior meatus. And this particular space, which is a very tiny space, which is lying on top of this particular superior concha, we call them as supreme meatus, also known as phaenoethmoidal recess. So we should have a clear idea what do you mean by the concha, which is a piece of the bone, and what do we mean by this particular space they are lying between these particular concas, which are known as meatus. How many concas are there? How many meatus are there? And what are the features that drives here in terms of the anatomy knowledge is concerned to understand the clinicals of this particular region. Now, normally in a living condition, this particular concas are covered or blanketed by the mucosal covering. The mucosal covering means this is covered with the mucosa, blood vessels, soft tissue structure which have got bloods and nerves supplying to it. That means it's a living tissue which is carpeted there, and this particular thing is wrapped around. Normally we do not see the bones exposed unless until we make the bone dry and look like this. So this is a dry bone specimen where you see these particular concas like the bones, how they are there, superior, middle, and inferior concha, and the space between them we call them as meatus. Superior meatus, middle meatus, and inferior meatus, like this. So this is the dry bone specimen, how it looks like, and this is a living specimen. This particular thing which you are familiar with, we have a cross section, sagittal section like this. If you haven't seen that, we'll be exposing that to see you as well. I think you have already seen that. And this particular inferior concha, we already have seen that they're very much prominently present. So the space above this particular inferior meatus, we call them as middle meatus. Inferior concha, we call them as middle meatus. The space below this particular inferior concha, we call them as inferior meatus, etc., etc. So these are the concas, which is the bones. These are the meatus, which are the recess of the space placed between them or under to them. And this particular, out of these, the inferior concha is the largest one and broadest one, is visible, more pronounced amongst these particular spaces which is concerned. Once you have this particular space is not an empty space. There are some opening of some sinuses or something which is getting into it. So that's what we have to understand, that each particular space, what the feature that is present on it. So we take each of the space and learn about this particular special feature of this particular spaces which is related to. So we take this particular supreme meatus or sphenoethmoidal recess. The space that means lying above the superior concha, we call them as sphenoethmoidal recess. That means it's bounded above by this particular roof of the nasal cavity. That means the sphenoid bone, this particular body of the sphenoethmoid bone, which is making the roof, and this below it is limited by this superior concha. In between them, we have a very tiny cleft there, which is known as sphenoethmoidal recess. Now, within this particular sphenoethmoidal recess, we see an opening coming here, which is coming from this particular sphenoidal air sinus cells. We call them as sphenoidal sinus. This is a space which is lying within this body of the sphenoid, and this particular body of the sphenoid space is also lined or covered by this mucosa. That makes this particular space is called as sphenoidal sinus, and this particular sinus opens into this sphenoethmoidal recess. What do you mean by that? The air gets into this nose and gets into this particular sinus and gets out. So functions of this sphenoid is humidification, purifications of the air, etc., etc., and as well as give this particular bone or make this particular skeletal bone lightweight. So this particular sinus, which is having this particular cavity within this sphenoid bone, we call them as sphenoidal air sinus, which has an opening which is communicating with this sphenoethmoidal recess. So which is communicated with it. Now, we have this particular other sinus, which is known as superior meatus, which is another meatus. That means this particular meatus, which is lying under the superior concha. So it is lying between the superior concha and middle concha. This is a narrow space. Within this particular narrow space, superior concha, we see there's opening of the posterior ethmoidal air group sinus that is opening into it. Similar to this middle concha and this particular inferior concha, in between them, we have this particular space, we call them as middle meatus. Within this particular middle meatus, which has an additional feature, itself the middle meatus, the lateral wall of the middle meatus, the features on it itself could be exam breakpoint short notes, like features which is there. Within this particular middle meatus, which is like a little bit broader, we see a cleft or semilunar cleft there, which is opening in here. We see a bony cleft or kind of like a gap which is present within this particular middle nasal meatus. This gap which you're seeing here, we call them as hiatus semilunaris. So this particular gap which you're seeing here, which is present in this particular region, we call them as hiatus. So this particular hiatus looks like a half of the moon. That's why you call them as hiatus semilunaris or semilunar hiatus. Within this particular hiatus, we can see that there's above this, we have a bulging of the bone. We call them as bulla of ethmoid bone. So this particular bulla of the ethmoid bone, which is ethmoid infundibulum, which is bulging into it. Within this particular ethmoidal bulla, which is lying over here, anterior part, we have an opening of these ethmoidal air cells. Anterior ethmoidal air cells in the frontal nasal sinus or frontal sinus, which is opening into it through this frontonasal duct. And then into this particular hiatus or the gap, we have the opening of the maxillary sinus and middle ethmoidal sinus. So we'll be coming into the sinuses, then this particular opening will be more meaningful to understand what this particular sinus and how this particular sinus. What you are seeing here, the opening or draining port of this particular sinus into these particular spaces. Now we are left with the inferior meatus. Inferior meatus, which is lying below the inferior concha, this particular space is opening over here, lying here, is coming from the nasolacrimal duct. That means whatever the tear that is coming, it is coming from this particular lacrimal gland, running through this particular external aspects of this orbit or eyeball, and scrolling to the medial end of this particular eye, and this we call them as angle of the eye. We have a collecting point over there, we call them as puncta, and through this puncta, it is draining through this tube, we call them as nasolacrimal duct. Now, this nasolacrimal duct opens into the inferior nasal meatus. So, these are the different opening of these different, these are the different meatus which receives the opening of various or several substances. We'll be talking about this particular opening, and then we'll go to this particular sinus. Then we will clarify more about these particular spaces and this opening in it. Coming from here, going to talk about the mucosa. As I am saying, this particular bones which you have, the concus and the septum and everything, the bony skeleton is carpeted by this particular mucus. That means we have the blood vessels, nerves, everything present within this particular live tissue, which is the mucous membrane, which is covering into it. So we have basically this particular mucus which is wrapping around, give this particular region a texture which is a moist texture. Now there are two types of the mucosa which is present in here. The majority of the mucosa which is lined over here, we see that this is blue, and this is red which is lying on the posterior or posterior superior aspect of the nose or nasal cavity, which is related to the roof of the nose. So there are two distinct points about this particular mucosa which is lying in the rest of it and the superior part of it. Now, what are the importance here? Whenever we are doing this clinical surgery, this demarcation matters. Reason we're talking about. Now, this particular nasal mucosa is highly vascular. This is visible. If you throw light through your external nasal cavity opening to the nasal part, you'll see it's red. The mucosa, it's very red out there. So it is kind of like a highly vascular if you see that particular mucosa. Now, which is the mucosa that is lying on this region, that means it's lying to the roof part, it is avascular or less vascular. This demarcation is very striking, and we can see that when we are doing the surgeries. Now, this demarcation we have to understand when we are doing the surgery, because in this region, the mucosa, we call them as olfactory mucosa. This olfactory mucosa are neural tissue rich. That means we have the tons of nerves which is present on this particular region. And this nerve which is coming here is olfactory nerves. By doing any surgery in the nose region, if you are doing any surgery in high nasal region, in this roof region, if you scoop too much region, we lose these olfactory nerves, and eventually the patient loses the smell power. So this thing you have to keep in mind when you're doing surgery. The rest part of the mucosa is vascular. That means it's highly vascular, and it is very fragile and a moist mucosa because it's tons of mucus secreting glands which is present in there. So this respiratory mucosa, demarcations of the respiratory mucosa matters clinically, and as well as you have to understand these demarcations of this mucosa, which part is lying with this vascular mucosa and which part is avascular mucosa and why. As I'm mentioning, this thing highly vascular. That means we have a tons of blood flow which is coming here. We have 6 to 7 arteries feeding this particular nose and nasal cavity and this region. We have a branches from different arteries pouring into and making this particular entire mucosa highly vascular. Take it what? If you have a highly vascular mucosa, if you have any breach into this point, a 0.1 millimeter breach will lead to heavy bleeding. That's why anything, if it is bleeding inside the nose, it bleeds really heavy. That's what we have to learn over here. We have the 3 sets of the arteries coming from facial artery, coming from this maxillary artery, and ophthalmic artery. They are pouring the blood flow into this highly vascular nasal mucosa. We call them as anterior and posterior ethmoidal artery. They are coming from this olfactory arterial branches. Maxillary artery sits the branches which is related to the palatine, greater palatine, sphenopalatine artery, and this facial artery gives the labial branches of the artery and the lateral nasal branches. All these branches network towards it, and anastomose within this particular nasal mucosa vascular part and supplies this region. Reason for this particular region of this have vascular, and as a result of this same architecture of this particular arterial network also exists within this particular nasal septum. Now we see this nasal septum, we have seen that it can be divided into 2 parts, anterior part and the posterior part. Anterior part of the nasal septum, as you see, the anteriorly we have this particular point where it is circled over there. This circled area on the anterior part of the nasal mucosa, where we see that anastomosis of these particular 6 arterial branches coming together and making this anastomosis point over here, giving a name there, we call them as Kesselbach area. So Kesselbach is a German physician who basically devised and figured out this particular region. Now we see this particular region, anterior part of the nasal cavity, which has got anastomosis over there, is very prone to have injuries. We'll talk about these particular injuries in 2 aspects. Now, as I'm mentioning, this is related to the anterior part of the nasal mucosa. That means this is an accessible part of the nasal part. That means the kids who are prone to have injuries into it. How? The kids already, most of the times we see that the kids has a curious nature and they have a habit of poking nose. Many of us also have the habit of. But anyways, the kids have a basically more intent to have the poking nature towards the nose. They poke this and they have this particular nails which is relatively sharper, and they breach this particular region. And if you breach this particular Kesselbach region, which is a highly anastomotic region of this, and it bleeds. And that's why this bleeding, which is coming from this Kesselbeck region, we call them as epistaxis, is very more common in case of the children. So this is one entity. This other entity is that the older individual, where they have this particular blood resistance is very high. That leads to this particular vascular hypertension. We call them as essential hypertension. The old elderly individual, again, if they have this particular high blood pressure, this particular blood vessels which is present in the Kessel's region can rip. Again, it can bleed. And if it is ripping and if it is bleeding, again, it can lead to this phenomenon. We call them as epistaxis. So this particular phenomenon, which is involving the rupture of the ripping of these blood vessels into this particular Kessel's region, we call them as epistaxis. Prone individual are kids or elderly, depending on the two different entities on this. Now, this is one of the explain why kind of question they give in the examination. Like epistaxis is more prone or more common in children, and epistaxis is more common in older individuals. You have to explain it with this anatomical basis, how this particular blood vessel, which area is there within this particular nasal septum, how this particular thing is related to this particular bleeding. Coming from this interior of the nasal supply to the exterior of the nasal supply. The outside of the nose is supplied with this particular nasal artery which is supplying to it. We call them as dorsal nasal artery, branch of ophthalmic artery, lateral nasal artery, etc., etc. They are supplying to it. The exterior of the nose is not that important clinically, but this particular exterior of the nose is more important in terms of the venous drainage. Now, this particular region of the exterior of the nose, all the blood vessels which is coming from the exterior of the nose to the interior of the nose, they join together and drain to a group of lymphatics which is known as sphenopalatine veins. Now, this particular sphenopalatine veins drains to the deep facial veins and ophthalmic veins. Now, take it what? This particular vein networks which is coming from the exterior of the nose and as well as interior of the nose, they join together, makes these particular veins, and they drain to this area of the venous drainage. We call them as cavernous sinus. So as a result of this, if you have this particular area of this nose or this particular interior and exterior of this particular nose is exposed to have infections because of this particular veins which is coming over here, forming a vein which is known as ophthalmic vein, forming a vein, sphenopalatine vein, forming a vein which is deep facial vein, they are connected to deep veins in the brain which is known as cavernous sinus. As a result of this, all this particular blood which is flowing on carry the infection from this nose, nasal cavity, can take this particular infection to this central nervous system. And as a result of that, this particular cavernous sinus may be infected and leading to this particular critical clinical condition. We call them as cavernous sinus thrombosis. So that's why this particular nose region and as well as this particular upper rib region, we call them as danger region of the face. We learned about in a face description region. So again, this thing again comes over here, danger area of the face, why it is important, how this infection from the danger area of the face and the nose reach and travels to this brain region through which number of veins. So this is how we have to explain. And majority of the times, you're listening or not listening, doesn't matter. You should be able to answer it properly. If you are not writing it properly, you won't be getting credited for this. Okay, so prepare it very well about this danger area of the nose and how come this particular danger area is called danger area. What do you mean by this? Now, coming from the vascular supply to this particular nerve supply, the interior of the nose region, we have this olfaction. This is taking part of this particular special sensation. But the interior of the nose also have the general sensation as well, touch, pain, temperature, whatever the sensation is there, that has to be carried through some nerves. So this particular interior of the nose can be divided into two parts by this particular line which is splitting here, bottom part and above part. Above part of this nasal cavity which is lying over here is drained by some nerves which is taking the sensation there. The bottom part is taken by another nerve. So this nerve which is taking the sensation from the above part of this part of the nasal cavity which is taking the touch, pain and temperature sensation is coming through V1 or ophthalmic division, which is coming from bottom part, which is coming from the lower part of the nasal cavity, which is going through the V2, that means the maxillary division. The maxillary divisions of Maxillary division of trigeminal nerve. So this mucosa, the sensory supply differ from the above and below, how these things are taken to it. And this is where we are talking about the olfactions, which is prime important for us. We understand this particular olfaction is taken by this olfactory nerves, which is housed within this olfactory mucosa. We know where is the olfactory mucosa is placed and how this particular olfactory nerves coming from this particular, like a periphery from this region, taking to this cribriform plate of ethmoid, going to this particular olfactory bulb and drains this region. Now this is the exterior of the nose, which is supplying to it. Rest all part of the nose supplied by the V1, that means this particular ophthalmic division. The ala of the nose, the spreaded part of the nose, is taking the sensation from this V2. Coming from this lymphatic drainage, the vestibule part, which is lying here on this particular exterior nasal opening, is draining this lymphatic drainage into this particular submandibular group of lymph nodes below this particular region. So if you have a boil or pimple in this region, the submandibular group of lymph nodes will be enlarged. Rest part of the nasal part, or vestibule, root of the nose, dorsum of the nose, everything drains to deeper group of lymph nodes, which is going into it. Back up nahi, taito? Back up nahi? Nahi. Coming to what is important for us, again, forming from the nasal cavity, architecture, clinical part into here, we call them as paranasal sinuses. This is what you have to understand. This is a 3D picture which is projecting something like that. Not exactly, but maybe just like a represent the majority of the understanding of this paranasal sinus. Now, what do you mean by the paranasal sinus? You have to know this, what is it? So, this particular nasal mucosa, which is present within this particular nasal cavity. Now, this respiratory cavity, as it is growing, with this time, facial skeleton is growing, this nasal mucosa is expanding as well. Now, this nasal mucosal expansion is going on different direction as we go. So, whatever the surrounding bone to this particular nasal cavity we have, the nasal mucosa grows into it. Now, as this particular nasal mucosa grows into the surrounding bone, it creates a cavity within these neighborhood bones, which is next to the nasal cavity. So, what are the neighborhood bones which is related to the nasal cavity? On top, we have the sphenoid bone and the frontal bone. It grows into them. And this particular expansions of the nasal mucosa getting into it and makes some kind of chamber which is lying there. This particular nasal mucosa expands laterally, moves to this particular maxilla on the right side and left side towards this particular cheekbone, zygomanic bone as well. This nasal mucosa expands posteriorly. We get this bone which is known as ethmoid group of cells which is present there. That part also invaded by this nasal mucosa. As this nasal mucosa is growing, invading and getting into this particular bones, they are housed and grows into. So we call these particular expansions or respiratory expansions of the nasal mucosa as paranasal sinuses. Now these particular paranasal sinuses are also lined or covered by the same nasal mucosa. That means this nasal mucosa, the epithelium or this particular blood vessels and the nerve supply which is coming from here also grows into the nearby bones and over here. So from this nasal mucosa inside, it is moving up, getting to this frontal bone, creates a sinus within this frontal bone. We call them as frontal nasal sinus. If it is going backwards into this particular region, we call them as ethmoidal group. It is moving above and this particular posterior direction, we call them as sphenoidal air sinuses. If it is moving on the lateral side, we call them as the maxillary nasal sinuses. So it is growing into different neighbor bones and grows into it. So we take each of these particular nasal sinuses and understand what this particular sinus is holding out here. So as I am saying, this particular nasal mucosa which is coming from the nasal cavity moving above into this frontal bone and makes this particular chamber or cavity in some part of this particular frontal bone which is lying in the front side, we call them a frontal sinus. So this particular frontal sinus is growing into this particular nasal sinuses, growing into this frontal bone, has a communication down through this particular nasal mucosa. So it is from opening into this particular superior meatus where this particular nasal sinus frontal region is draining into it. This is one of the sinus which is present in the frontal bone, which is draining to the frontal nasal duct and opens into the middle meatus through this hiatus semilunaris. ethmoidal cells. Within this particular ethmoid bone, the sinus is growing, and this particular sinus can be divided into 3 parts. We do not want to complicate at this level, because in the ENT sessions we learn these different parts of this ethmoidal sinus. But for clerical distributions, we have this particular sinus divided into anterior part, posterior part, and in between posterior and anterior part we have this middle part. It looks like a bunch of grapes, this particular ethmoidal air cells, which grows like a bunch of grapes having a stalk attached to it. Now this particular sinuses, which is ethmoidal air sinuses, anterior, middle, and the posterior, they also drain into this nasal cavity within this particular meatus. This particular anterior meatus and the middle meatus, they drain mostly into this particular individually or collectively into the space we call them as middle meatus. The posterior one drains to the superior middle meatus, superior meatus. Now coming from this meatus we talked about, it is growing above and posteriorly into the sphenoid bone or body of the sphenoid, grows in there and hold a sinus space there. We call them as sphenoidal sinus. This particular sphenoidal sinus opens into supreme meatus, also known as sphenoethmoidal recess. Now most important to us, this is also, we see that exam question are asking about this describe of the sinus which is involving this particular middle sinus. So middle meatus, which is opening here. So this particular meatus, which is lying on the maxilla bone, is largest of all, is earliest to develop, and when we are born, nearly by the age of 1 year, it has a normal adult size nearly. So this particular maxillary sinus, which eventually grows into this particular maxilla, which is lying over there. It looks like a D-shaped structure. You see this particular skygram picture. This is not a skygram. This is a CT. This is an MRI section, which is a cutting through the sinuses, which is exposing different sinus. So this is orbit, which you're seeing here, right and left orbit. This is the nasal cavity, the septum, which you're seeing here. The conchas are visible, and you can see that this particular space, which is lying on side of here, we have the maxilla bone. So within this maxilla bone, right and left, maxillary sinus is there. The detailed anatomy of the maxillary sinus you have to know. What are the boundaries of the maxillary sinus? What makes this particular maxillary sinus happen? It has a floor, it has a roof, it has a walls which is related to it. So if you see this is the roof we can call it, which is related to the orbit or inferior plate of the orbit, which is related to it. This is having a floor which is related to the maxilla, which is lying on these regions. This particular part of this particular sinus, which is going into it, it makes an apex and related to the zygomatic bone, and this is related to the lateral wall of the nose or nasal cavity, which is lying on these regions. And then as well, this particular sinus is holding a space, we call them as sphenoidal sinus, maxillary sinus, which is lying here. Now, this particular maxillary sinus has an opening which opens into the middle meatus, which is going through and draining it. So this is the opening where you can see it is opening into the maxillary, from the maxillary sinus into space which is known as middle meatus, going through this particular region. Now, the right side and the left side, we have these two maxillary sinuses, which is present in here. The nerve supply and the blood supply, which is related to, which is known as alveolar arteries, which is a branch of maxillary arteries, and the nerve supply, which is coming from this particular maxillary nerve, which is branch of V2 divisions, which is supplying to it. So this particular maxillary sinus, the detailed anatomy of this, sometimes we see that individually, may be coming as an exam short note, which is coming to describe the different parts of the maxillary sinus, because this is one of the largest and this is the one which need to be tested. Apart from that, these sinuses and where do they drain, this particular orientation is important for your practical exam, theory exam as well. We just like give the sagittal section, ask you about the meatus, identify the meatus and conchas, and what this particular meatus and conchas are draining into, what kind of sinus is draining into this particular spaces. So this particular chart that you have to keep in mind, along with this particular opening of this nasolacrimal duct, the tear gland, which is pouring the secretions, which has to keep in mind regard to this particular drainage point. Coming to the clinicals, fractures of the nose, one of the commonest thing which breaks because it is a projected part of the face, and this particular nose, if it is broken, easy to fix because this is displacement of this particular nasal bones is really less. Now coming to this particular grave anatomical problem related to this particular fracture, if it is a complicated fracture or it may be just like injuring the deeper part of this particular bone, breaking this cubiform plate of ethmoid. As I have mentioned, the cubiform plate of ethmoid, through that cubiform plate of ethmoid, we see the olfactory nerve running through. And as well as on top of this cubiform plate of ethmoid, we have the brain, and which is covered by dura mater. So if we have the cubiform plate of ethmoid broken into this particular region, root of the nose and deep into it, we may have injuries to the dura mater. If we have this injury to the dura mater, that exposes the subarachnoid space lying deep to it. If the subarachnoid space is exposed, that means we have the CSF which is also at threat. That means the subarachnoid space, if it is breached because of the dura mater breach, we can have a leakage of the CSF through that particular point. And if the CSF is leaking, that will be leaking through this particular nose or nasal cavity, and CSF will be coming down, trickling through this nose. So this clinical condition, we call them as CSF rhinorrhea. That means a running nose, the CSF is coming out. So this anatomy you have to mention. Whenever you have to explain that CSF rhinorrhea, explain it. You have to explain this particular roof part of this particular anatomy, or roof skeleton part of the nasal cavity, which makes this cubiform plate of ethmoid, sphenoidal body, etc., part of this bone which is making here. If this particular cubiform plate of ethmoid, which is a kind of sieve-like structure, breaks down because of the injuries, or if not injuries, if the bone itself melts down, these injuries to this dura mater leading to this particular exposure of the subarachnoid space, that leads to this leakage of the CSF through the nasal cavity, and this particular phenomenon is known as CSF rhinorrhea. So this is one of the clinical explain why kind of question that may be coming up. Other thing, deviation of the nasal septum. This is made of partly cartilage, partly bony. Now the union of this bony, partly cartilage, partly bony, may not be a midline straight structure, may have a deviation. This is one of the commonest deviations what you see in a clinical life about this particular deviated nasal septum. So this is how it looks like during this particular examination or during exposure. You see that this is a midline septum, and you see that how curved it is over curvature points which is lying to it. Now this is what we're talking about, bleeding through this particular external nose. We call them as epistaxis. It could be anterior epistaxis, it could be posterior epistaxis, depending on how the blood is coming out. If the blood is coming out through the external nasal opening, we call them as anterior epistaxis. If it is coming from the posterior nasal opening or choanae, we call them as posterior nasal opening or posterior epistaxis. Reason, we understand that this is a highly vascular mucosa. If it is having injuries in children or in adults, depending on this particular clinical points, we understand why it bleeds and what are the arteries that is making an anastomosis and reefs and arteries, which is branches of the ethmoidal, anterior posterior ethmoidal, greater palatine, lesser palatine, facial artery, labial branches, etc., etc. Those are the things, those 6 branches that you have to mention coming over here, making an anastomosis, getting into it. Sinus. This particular sinus we have mentioned, frontal sinus, sphenoidal sinus, ethmoidal sinus, maxillary sinus, all of them could be infected. They may be infected because of the infection, because we take this air, this particular air contains these germs, everything. This nasal mucosa may be affected. As this nasal mucosa is affected, the same expansion of the nasal mucosa, which is getting into this particular sinuses, will be infected as well. That leads to the sinus infection. We call them as sinusitis. Now this sinusitis may be acute. That means it happened right now. It may be chronic, maybe running for a period of time, 2 weeks, 3 weeks, 4 weeks, something like that. Now, if this particular sinus infection or sinusitis, which is running for a period of time, that means chronic sinusitis, we have a tender point within this particular sinus region. So, if this chronic sinusitis is there, involving this particular frontal sinus, if you press this individual, the forehead, this region where this frontal sinus is there, the patient will be complaining of tenderness. We call them a sinus tenderness. So, these are the points. If we press on in a patient having chronic sinusitis, this particular points will be painful. We call them a sinus tenderness elicit examination. So this is what you have to know, the surface marking or surface morphology about the sinus and how to press it and why, what are the interpretation out of pressing that in terms of chronic sinusitis. Maxillary sinusitis. Again, coming back to the maxillary sinus, this is one of the areas that you have to prepare well, because this is the area we see that number of times we see the clinical questions and as well as the anatomical question is coming. And when you are addressing this maxillary sinus, you have to mention about the clinical point. The infections of the maxillary sinus, we have to mention it as a maxillary sinus. So we have projected a picture of this maxillary sinus, which is present beforehand. This particular picture, which is a different picture. So this particular sinus, you see that it is marked with different colors, different letters, A, B, C, D, E. So out of these, which is the maxillary sinus?
Which letter? A and B. What are the, is the A and B the same or are they dissimilar? Is the A and B is similar or it's dissimilar? Now see, you have to pass the examination. I'm talking to you guys. I'm talking to you guys. You have to pass the examination. By smiling, you cannot get your numbers. So, if you see this A and B, what are the difference between A and B? One is black, one is gray. So, what normal is that we have to know, then we can interpret the abnormal, right? Now, what the normal sinus is occupied with, it is lined with or covered with this particular mucosa, which is lining to it, and inside this particular sinus, we have the air filled in. So, how this particular air filled space looks like in a skygram? It looks like black. So, if it is looking like black, black is the normal thing. So, out of this A and B, the B1 is black and A1 is gray. That means the B1 is healthy and A1 is unhealthy. Now, what this A1 is known as? Sinusitis. Now, this particular sinus is occupied by mucus, which is coming from the sinus secretions, which is lying over there. That means the B side is affected. So, that interpretations that comes over here is the maxillary sinus of this A side. That means on the right side, it is marked on right side and left side. So, right side maxillary sinus is infected. We call them as right side maxillary sinusitis, whereas the left side is a healthier side. So, this particular interpretation is also good. See, rest of the sinuses like E, ethmoidal air sinuses, frontal we cannot see it properly, which is a little high up, and sphenoidal also we cannot see it properly. So, this interpretations of these particular sinuses and the maxillary sinus inflammations is very important. Coming to this particular olfactory nerves, which is easy to understand over here that we have mentioned. So, this olfactory nerves comes through this olfactory mucosa, which is lying in the superior part of this nasal cavity. So, this is the roof of the nasal cavity where this particular olfactory mucosa is there. Within this olfactory mucosa, the receptor cells of the olfactory nerves are there. So, this is hanging over there, which is known as olfactory nerves, which is now running like rootlets. Several thousand of these rootlets are hanging over there. These rootlets coming over here pierces this cubiform. This is the magnified view from here. So, this is a cubiform plate of ethmoid which has a pores in it. This olfactory mucosa, which is lying over here, had tons of receptor ends from the olfactory nerves, comes over here and drains into this particular yellow structure. This is olfactory bulb and olfactory tract. So, this olfactory nerve takes the sensation from this roof region, goes inside, and this particular region goes or gets into this particular olfactory bulb, olfactory tract, and olfactory area in the brain takes the sensation. Now, this is what we are talking about. So, if this particular cubiform plate of ethmoid is damaged, we have the overlying brain which is covered by this particular CSF, which is covered by the meninges holding the CSF will be exposed and resulting in leakage of the CSF through this cubiform plate, and once it pierces through the cubiform plate, it trickles down to this nasal cavity to this exterior of nose. We call them a CSF rhinorrhea. At the same time, if you have a breakage of this cubiform plate, these olfactory nerves which are running through will be also trapped, and as a result of that, injury to these olfactory nerves will be there. So, this particular person may have the smell error. That means anosmia, or partial or complete. That means perception of the smell may be partially or completely may be damaged if you have this cubiform plate damage as well, along with CSF rhinorrhea. That is another concern related to this part. Now, coming back to this thing, olfactory nerve coming from this olfactory mucosa runs to the cubiform plate, enters to the olfactory bulb, and then to the cranial cavity which is related to it, then forms a tract and goes to the area of the brain which is known as olfactory region. How we're going to test it? We close the patient's eye and just like give a familiar smell to smell it out, closing one nostril at a time. Close one right side nostril, ask to smell. If you can smell anything, can tell the name of the smell if it is okay, or if you can smell yes or no, that is the first thing that you can just like note it down. If it is smelling, okay, fine. You may not be able to identify the nature of the smell, but if it is smelling something, then it is working. Do the same thing to the opposite side. Give some smell to the opposite side. Ask him to sniff, and if he can sniff it or any smell or not. That's the way we test this particular olfactory nerve testing. Now it may be, that's why I'm saying, loss of the smell, we call them as anosmia. Partial, that means partially loss of smell is there. Complete, that means complete anosmia. Complete or partial loss of smell will be there. So based on these particular regions, we test this particular smell sensation. And how this particular olfactory bulb looks like, the interior of the skull. That means you are looking into this region of this brain, we call them as base of the brain. This part we call them as olfactory area or olfactory surface, and this is known as tentorial surface. Within this, you see this particular olfactory bulb and this olfactory tract which is going down to this particular olfactory area on these particular areas of the brain. So this is how this particular olfactory tract, olfactory nerve, olfactory bulbs, anosmia, testing of these things comes over here. Just to summarize, we have to know about this particular nose, nasal cavity, boundaries, roofs, etc., etc. We have to know this particular about the nasal skeleton, which is making the septum. We have to know about the mucosa. We have to know about the blood supply of this interior of these regions of this nasal mucosa, and why it is vascularity leading to this particular bleeding fluid. We call them as epistaxis. In children and adult, this epistaxis varies, and why do they varies, and what are these things present over there. And then we go to this particular paranasal sinuses. What are the paranasal sinuses, where do they drain, and what this particular drainage point leads to us out of these paranasal sinuses, which is the largest one. The clinical anatomy indicates the largest one, which is the sinusitis, etc., etc., that we have to know. And along with that, the second cranial nerve, olfactory, how this olfactory nerve related to this particular cubiform plate, what's the effect of this particular damage to the cubiform plate in terms of explaining CSF rhinorrhea, in terms of explaining this anosmia, etc., etc., and how to test this CSF, how to smell this smell test or sniff test and do it clinically.
I think you have to from roll number 1 to roll number 50. Okay. I mean, I have at least up to 40 presentations were made, isn't it? So what is your own feedback about your own presentation? You just tell me. What is your own feedback about your own presentation? I do not cross talk. See, yesterday we thought that I will talk to HOD, then I will say that, sir, we all three will start gossiping and talking to each other without listening. Now, how one will feel? I mean, I think none of you talked to each other, none of you has concentrated on the mobile, but everybody heard what your colleague or your classmate is speaking. If somebody is speaking and somebody is making a noise in front of, it will cause too much disturbance to the speaker. It will draw the attention. And that's what exactly happens to us. See, if you don't like any class, I would suggest that in future, make it a point that those who want to hear, come to the first bench, to the bench, so that you can see it. And those who do not want, first and foremost, do not use mobile. You can say this is a crime during class. And talk, I mean, very silently if you want to talk. That is also not allowed. But if you want that your attendance will be required, for that purpose, I think attending class will not be required. You can do some homework also, whatever you like on the class. But don't disturb the class in future for anybody. Because everybody wants that the speaker, what he is telling, the audience will listen. That's the decorum of a class. And then only you will interact. I think at least it's my own comment that I am quite happy to see your presentation. All of you, whatever way you have done very good job. Everybody has done excellently. Of course, again, if you want to compare, if you want to make an examination, there will be first, second, third. That's a rule. You cannot escape from that. But that doesn't mean that one speaker who is speaking very well and who cannot speak today will not be able to speak better than him tomorrow or her. Okay? So that's the rule. You go on improving. So yesterday and day before yesterday, I told one thing to all of you. all the batches. The same thing I am repeating here. Write one thing, and you please write the same word whenever you will be opening a register. All of you are having a potential. I don't have any doubt about it. But it doesn't mean that you have to excel in medical sciences only. There will be other sides of your talents. So first write unleash, UNLEASH. Write it. Unleash, be it theoretical, be it practical. Bring a copy, at least register with you, so that you make a note and make a record an activity, whatever you have done. Because retrospectively, we have to see what you have done in the past, day-to-day activity. And I can tell you, after joining my service, almost I used to maintain a daily record logbook, what I have done on that date. And in every evening, I used to introspect myself, what I have not done. All these days have passed, what I have not done. And all important points, all important reports, whatever I have got in my life are with me. And that I make presentations wherever I go. These are invaluable documents to me. These are patient reports, these are abnormal reports, which I personally have encountered. The same thing you will definitely experience and make a record of it. That's how medical science progresses. So unleash, number one, unleash your means it is your, means my, in your case my. Untapped, UNTAPPED. Potentials, POTENTIALS. Unleash your untapped potentials. তার নিচে একটা সেন্টেন্স লেখো, সেম সেন্টেন্সটাই লেখো, শুধু একটা ওয়ার্ড অ্যাড করতে হবে। লেখো আবার, আনলিশ ইউর আনট্যাপড পোটেনশিয়াল। ওই আনলিশ ইউর হিতার্টো, HITHERTO, এটাকে একটু অ্যারো দিয়ে উপরে লেখো। এইটি মানে বোঝার চেষ্টা করবে। Those who will not be able to understand, do come. I'll explain. Not now, this is, I'm giving it to you. HITHERTO, unleash your hitherto untapped potential, unleash your, ওইখানে সেকেন্ড লাইনে লেখো, কারণ প্রথম পার্টটা স্যাটিসফাইড হবে at one point of time, but that second point will be never ending in your life. You have to continuously improve so long you remain alive. And that line will be applicable for that. Okay? So, with this very brief introduction, let me start today's discussion, that is CSF. Have you been ever told about CSF in anatomy or physiology class? Huh? Bolo? Huh? কি বলো? হিতার্টো মানে এখনই দেখো বাবা, এখন ডিকশনারি ফিকশনারি খোলো, সবটাই স্যার বলে দেবে, এখনই দেখো, এখন গুগল টুগল আছে, এগুলো আমি ক্লাস গ্রামের স্কুলে শিখেছি, গ্রামের স্কুলে ক্লাস 9 10 শিখেছি। হ্যাঁ, 9 10 শিখেছি এগুলো জিনিসপত্র আমার। তো এখন তোমরা যদি বলো, এখন এই স্টেজে তোমরা ইংলিশ মিডিয়াম স্কুল থেকে পাস করে আসছো, ঠিক আছে, পরে দেখবে। আরে আমি বাংলা মিডিয়ামের ছেলে, গ্রামের ধানের জমির পাশে স্কুলে পড়েছি, আর তো বাংলা মিডিয়াম থেকে আমিও পড়েছি। আর বাংলা মিডিয়াম আমার সেখানে বাংলা মিডিয়াম যথেষ্ট ভালো পড়ানো হয়, ইংরেজি আর্লিস্ট আমি ইংরেজি মিডিয়ামের লোকের চেয়ে ভালো জানি, এটাও তোমাকে আমাদের বলে দিচ্ছি। আমাদের এত বড় হাসপাতাল ছিল, তো আমাদের হাসপাতালে কম ডাক্তার ছিল, 138 ডাক্তার, সবচেয়ে ভালো ইংরেজি আমি জানি, আমি আজও বলে দিচ্ছি। তো এই ইংরেজি বাংলা মিডিয়ামে পড়ে যখন ইংরেজি জানবো না, এটা হতে পারে না, একদম ভুল ধারণা, তোমাকে আমি বলে দিচ্ছি, একদম ভুল ধারণা, আমি তোমাকে বলে দিচ্ছি, এখনো বলছি, আমার চেয়ে ভালো ইংলিশ। হ্যাঁ, HITHERTO। অনলি থিং তোমাকে একটা চেষ্টা করতে হবে, নিজে দেখাবো আজকে যে আমি ক্লাস 9-এ একটা ট্রান্সলেট করেছিলাম, তোমরা আজকে পড়ার চেষ্টা করবে, যারা ইংলিশ মিডিয়ামে এসে পড়ার চেষ্টা করো। আমি বাংলা থেকে ইংলিশে ট্রান্সলেট করেছিলাম ক্লাস 9 এখন পড়ি, তখন সেটা পাবলিশ হয়েছিল স্কুলে ম্যাগাজিনে। তো জানা যায় না সব ভুলভাল কথাবার্তা, গ্রামার সবচেয়ে ভালো জানে বাংলা মিডিয়ামের ছেলেরা, আমি এখনো জোর করে বলতে পারি। ঠিক আছে? English just a medium. We are translating from Bengali to English. That's all. Nothing great. Nothing great. So just see, you have not been told anything, any idea about CSF? Any idea? Because you see, this is a actually applied aspect. If you don't know the basic, it will be very difficult to understand the clinical implication of what CSF is, because you have to do at the end the testing part. So you have to know the background, otherwise you will not be able to understand properly. That's the problem. So keeping that in mind, basically my basic part will be basically biochemical parameters and interpretation, and to be very frank, to be honest, it will take only 5 minutes time to cover this topic, provided you know the entire thing. But since you don't know, today I'll discuss very briefly, so that I'll cover some amount of anatomy, some amount of physiology. And today at least, after going from the class, today finish reading CSF. Then you will remember. And at the end of the lecture, like other classes, like LFT or thyroid function test or diabetes, what I did, at the end, I wanted to know whether the LFT class, whether you can diagnose hepatocellular jaundice, obstructive jaundice or hemolytic jaundice. Similarly, in thyroid, hypothyroidism and hyperthyroidism. In diabetes, whether it is normal, whether it is impaired, or whether it is diabetes. Same thing will be applicable here. The 3 common things which you will see in your day-to-day clinical practice, particularly those who will be practicing medicine and general practice, they will be encountering meningitis cases. So there are 3 common types of meningitis. One is viral, one is bacterial, and the third one is tubercular. And you have to differentiate between the 3, among the 3 basically. So today, at least I will say, by seeing at least the CSF, you will be able to diagnose. If you cannot diagnose, or you are in a doubt, even if you do 2 tests of biochemistry, you will be able to diagnose properly and correctly what a tubercular meningitis, what is a viral meningitis, and what is a bacterial meningitis. In addition, where if there is any requirement, you can look at the hematological pictures also. That will be indicative. In isolation, I am telling you, if you are very much, well versed about the subject, without seeing the patient, by seeing the report, you will be able to diagnose. And today, at the end of the class, each one of you have to diagnose based on the report itself whether you are handling a case of any one of the 3 meningitis. If you cannot do it, the entire purpose of the class will be lost. And I am the most disheartened person. And today I think it is the last class of me for your session. So if you have any doubt, you can interact whatever classes I have taken on the way here and there in the campus. See, basically the salient features, try to remember all these things. Do not talk, please switch off your mobile. If you switch on, if I see anybody talking, I will simply stop and simply go out of the class today. Because today is Saturday, I want to finish it a little early also. So CSCB is present in the subarachnoid space. What is the space between the arachnoid space and the dura pia? Because meninges is composed of 3 layers. One is dura, one is arachnoid, and another is pia. So it's a subarachnoid space, means between the arachnoid matter and the pia matter. And in the ventricle system, we are having 2 lateral ventricles on either side, and 3rd ventricle in the middle, and the 4th ventricle down below. So it is present in the subarachnoid space, ventricular system, inside and around the brain, because it makes a fluid covering over the entire central nervous system, be it cerebral hemisphere, be it spinal cord. And CSF production is just like urine formation, it is an ultrafiltrate of plasma. What is an ultrafiltration? It is a membrane-bound filtration process by which the high molecular weight proteins substances are retained, while the low molecular weight proteins are allowed to pass through. And whether it is a urine, whether it is CSF, whether it is peritoneal fluid, pleural fluid, or pericardial fluid, all are essentially basically ultrafiltrate of plasma. In addition, the purpose of different fluids are different. Urine, we are passing it out, it's an expiratory product. So don't expect that the composition of urine will be same as of CSF. So CSF is having a different purpose because there is no lymphatic system in the central nervous system. The only drainage system is CSF of the waste product of the central nervous system is venous system and the CSF. And again, if you recall the pericardial fluid, brain is basically pumping. So it requires a lubricant around it. Lung is expanding. So lungs also require some amount of lubricating substances. And in the peritoneum also, peritoneum moves, there are several structures that are intestinally moving. So some amount of lubrications are required. So these are added. So that are basically called transudate, not ultrafiltrate. But the essential production is through ultrafiltration, the main fluid, on top of which these are added as a lubricating substances. But no such lubricating substance is present in CSF, neither in the urine. That's the difference. So CSF production will be by the choroid plexus. Choroid plexus is a tough vessels, just like glomerulus, and it is located within the lateral ventricles. And daily we are having a production of 750 ml at the rate of almost 0.5 ml per minute. But the total CSF any individual remains fixed. It is around 125 to 150. See, brain size of every person is not same. Therefore, the CSF will not have a fixed volume. There will be a biological variation. And that variation ranges from 150 to 250, 125 to 150. It's a very narrow range. Obviously, you do not expect that the volume of CSF will be the same as that of a neonate or a child. That amount will be less. Isn't it? So this is an adult picture. So CSF flow, basically it flows over the surface of the brain and the entire length of the spinal cord. So daily production is 750, but it is maintaining 125. So that means there is a continuous production of CSF and there is a continuous draining system. So CSF turnover rate is very high almost. It's 5 times, more than 5 times. Okay. So daily we are producing, every minute we are producing, we are also taking out some amount of CSF. Now, how the CSF is coming out from the cerebral space? That you must remember. See, you remember this part can come as an anatomy class, this part can come as a physiology, it can come in biochemistry also. How cerebral spinal fluid flows. It is produced in the lateral ventricle through the choroid plexus. Remember, that you must remember. That is the site of production. And if you recall the structure, have you not been covered brain in the anatomy class? Have you been covered? Cerebrum? So have you heard about lateral ventricle? So lateral ventricle, from lateral ventricle to the third ventricle, the opening is foramen of Monro on either side. So through foramen of Monro, it comes to third ventricle. From third ventricle, through cerebral aqueduct or aqueduct of Sylvia, it comes to fourth ventricle. From fourth ventricle, remember there are 3 openings. One is foramen of Magendie. Magendie, try to remember, M means stands for in the middle. So that will be easier to remember. And on either side there is a Lasca, foramen of Lasca. So it is placed laterally on both sides. And through foramen of this opening, the actually cerebral spinal fluid passes through into the subarachnoid space. Now that fluid, if you recall, this through the foramen of Magendie, which one is passing, is filling the entire spinal cord. And through the foramen of Lasca, it is covering the surface of the brain, cerebral cortex. And once this is formed, this from subarachnoid space, this spinal cord is basically drained into the system, in the venous system, through the arachnoid villi or arachnoid granulations. These are basically outputting of arachnoid granulation, this arachnoid matter. And that is basically the route of how the CSF gets absorbed. I can show you this picture, you remember. This is basically the arachnoid granulation. Okay. So from there through superior sagittal sinus, so this is the side and this is the superior sagittal sinus through which it drains. You see, but this flow will be possible only if there is a valve-like system. There is not a true valve at the subarenar granulation, but there is a valve-like mechanism so that it allows only one-way flow. Otherwise, blood will enter into the subarenar space. The pressure in the subarenar space of the cerebrospinal fluid is high, so that the fluid flows from cerebrospinal fluid to venous system. Okay. So the clinically most important part is that this space, in this space, you just write down this thing very clearly. I will repeat it once more. In the subarenar space, CSF comes in contact with perivascular spaces around the blood vessels. And actually in meningitis, inflammation occurs here. And because of the inflammation, leaking occurs of the cells and the proteins from that site. Okay. So that site it enters the cells and the protein membrane into the cerebrospinal fluid. And based on its composition, again I repeat, you will be able to diagnose these three cases. So this is, I have said this will be told in detail about in your anatomy class, just to cover cover the matter where the aragonal granulation is located, where the superior sagittal sinus is there. This is a histological structure. This is most simplified structure. Histologically, definitely you can see. This video I'll show you. See, one MRI picture I have, this is a live MRI picture. You could have seen that brain is floating literally outside the brain. So just look at the picture. It is formed in the lateral ventricle, flowing through the third ventricle, fourth ventricle, and through the spinal cord it is going, and again it is coming, it's back, it is filling the covering part of the both the hemispheres, and through which this aragonal granulation it is being, passed through. Okay. Have you seen this thing? So it will be clear. Should I show the video once again? Okay. Hold it. See, this is found in the lateral ventricle. Clear? It is coming to the third ventricle. Okay. It is coming to the fourth ventricle. Okay. Now one part is going down. That is spinal cord. And the rest, this is the foramen of meningeal. Through foramen of Laska, you see, this is coming through. See, this covering. Sides are covering. This is superior. This is aragonal granulation. Aragonal granulation. And this is superior sagittal sinus. Is this part clear? Now you must not be able to forget.
Obviously, you have the people in the UK.
So there is a functional MRI picture which is not I have been opening here. So as I told you earlier that this CSF volume is almost about 125 to 150 well, at any point of time in any individual, but there will be a distribution. See, it is formed in it is most common in the cranial subarenar space because it is acting as a fluid cover over the brain to protect from injury apart from the bony structure that is a skull which we are having. It is making as a buffer which I will discuss. And in the subarenar spinal space, this is only 25 because that is a little bit of lower dimension. And lateral ventricle where it is produced, you can see the volume is 25 to 30 ml. And third ventricular size and fourth ventricular size is very small compared to the lateral ventricle. So their volumes are also, CSF volumes are also less. So these functions, these 5 functions you must remember throughout your life. One is buoyancy. It is brain is basically remaining suspended within the suborganous space and is maintaining its buoyancy. Suppose if you are protection from injury, suppose somebody gets a hit on the brain, and all of you, I think all of you have fallen somewhere or other, but all of us have never sustained any head injury. Why? Because of the mechanical support of the skull, number one. Number two, if there is any movement of the brain, the subordinate space, subordinate fluid also moves simultaneously. So brain will not be allowed to be hit on the other side, on the skull. A sudden shifting of the subordinate space also, subordinate fluid also. Okay? So it is acting as a shock absorber. Third is, but if the impact is very severe, bone will also be damaged, the subordinate protection layer will also not be able to protect, and it will sustain definitely a cerebral injury or a brain injury anywhere in the area. Number 3 is prevention of brain ischemia, and number 4 is homeostatic regulation, and number 5, as I told you, there is no lymphatic system, so removal of waste product. These are 5 functions of cerebrospinal fluid that you might be told in your physiology class. Now, चले जाओ. If you want to go home early, why do you come to class then? This main part you are not hearing. So the purpose of coming to the class is totally lost. Anyway, you can go. This is not a jail that you will be kept in custody. Anybody who is wants to go, please, you can go out. No issue. But at the end, those who will be presenting, they will be able to diagnose this case. See, since it is an ultrafiltrate, as I told you, just look at these 2 points. First and foremost, lipid and bilirubin is conspicuously absent. As you see in the urine also, there is no lipid, but bilirubin is present during jaundice only. That part is totally different. In CSF also, in brain also, bilirubin enters, but that is in the pathological condition. That I told you, congenital hyperbilirubinemia. In that condition, definitely it appears, but there is a higher concentration. Normal, it is not present. I am talking about normal thing. So here the protein is 7 gram per deciliter, means 7,000. In contrast, the lumbar region, you remember this lumbar region, forget about the ventricle and systole, it is 15 to 45 milligram. So why I have chosen 7? Because the normal total protein value is 6 to 8. Okay? So that's why I have taken 7 for your own understanding. So if I take a middle of it, say 15 to 45, if I take 35 as the normal value of CSF protein, then if you divide that 7,000 by 35, we will get 200. So serum protein into CSF protein ratio is 200:1. Why? Why is this difference? Because it will not allow the high molecular weight protein. Only small molecular weight protein can come out, and albumin can come out, because albumin has having a molecular weight of 67,000. But higher molecular weights will not be able to come out. IgG, that is immunoglobulin, that the smallest size, the molecular weight is 150. And if you take a dimer of IgG, that is basically IgA, that is a joining chain, at least you will get more than 3 lakhs, because 150, and there will be joining chain. If you take IgM, that's a pentamer. That is 5 into 150, 750. In addition, there is a J chain. So that's a high molecular weight protein. These will be definitely present. These might be present if the permeability is very high, or if globulin is synthesized. And this is, at cerebrospinal fluid itself, and it is shown in some immunological diseases. But that is a rare thing. See, serum CSF, serum Ag ratio. What is the serum Ag ratio? 1 to 1.5:1. If you remember very correctly, that albumin level in the blood is higher than globulin. So that's why the ratio is 1 to 1.5:1. But here you see the difference, serum protein into CSF protein, it is 200 into 1, because this is an ultrafiltrate. And similarly, same thing is true for globulin also. See, globulin is present also. It is not that it is not present. It is present. This is 3.6, that is 3,600 milligram, and this is 0.0155 gram. Now, if you convert it, it will be 150. 15 only, isn't it? You multiply it by 1,000, because this is basically 3.6 by 3,600 gram. Why I have said? Because we express serum in gram, and we express the CSF volume in milligram. There is 1,000 times less. That you must remember. Out of these all parameters, you see, if you look at the blood glucose level and CSF glucose, it is almost 60% of what the blood glucose level is. Usually, blood glucose and CSF glucose doesn't occur simultaneously. It takes about 30 minutes to 4, 5, 6 hours to equilibrate. So, at any given point of time, since many of us are diabetic, their blood sugar will be blood glucose level will be high. So, don't expect that everybody will be having this range. Those blood sugar whose blood sugar is 200 to 250 or 300, do you think that CSF will be 45 to 50? No, that will be high. That will also be high. That you must remember, because nowadays we are having a good number of diabetic patients, and they can also suffer from meningitis at one course of time, particularly after sustaining any head injury. So, their CSF analysis, while you must be very much careful. You have to collect also simultaneously a blood sample, and it should be mass than less than 0.6% ratio, because it is that part you must remember. But if there is an abnormal lowering of glucose, black and white, it indicates the bacterial meningitis, which I will discuss. If you look at sodium, it is slightly higher. If you look at magnesium, it is higher. If you single item, if it is asked in your examination which parameter is higher in CSF concentration, at least you must tell chloride first, and then you tell magnesium. Lower side, bicarbonate is little bit lower, and similarly sodium is a little bit higher. But as a whole, you try to remember all the parameters are lower than plasma, except only chloride, because there is a maintenance of balance, ionic balance. Everything is low on one side, everything will be high on one side. That is, donor membrane equilibrium will not tolerate that thing. So, equilibrium has to be maintained, and for that some negative ions are high here. So where from you will collect the blood? From any individual? Where from you will collect the blood? From? Median cubital vein. Okay, from hands we are all collect. If the hand is not available, we can collect from here. So, peripheral veins, normal route. So, from a child, from a baby, newborn baby, that will not be sufficient. Fingertip, yes, for common parameter, definitely for glucometer it can be used. For if we require much more investigations, that will not be sufficient. But where from we will get it? Any idea? Any idea where from we will get from a baby blood? Finger prick, if you make a finger prick, how many drops you will get? That will not be sufficient. At least we will be requiring 1 ml, minimum 1 ml of blood for any investigation. And I am telling you, in the newborn baby, the fat cell volume is very high, almost 70-80%, at times 85%. We will hardly get any plasma. So, from where you will get the blood for a baby? That needs to be investigated. You have got it out, you want to do the investigation. Only glucometer is not sufficient. Wherefore we will collect. Any idea? You just tell something, I want to have an interaction. It's a group discussion type of thing. That's why we have been divided. You just tell some wrong things, I'll rectify. পায়ে কোথা থেকে পাংচার করবো বলো? ঠিক আছে, পা বলে পায়ে কোনখানে পাংচার করবো বলো? তোমারই বাচ্চা না, ঠিক করো, এবার তুমি ঠিক করো, বলো কোথায় পাংচার করবে? তুমি ডাক্তার, তুমি পাংচার বলো। This is what will happen. See, from brain, you will puncture the brain. Blood, yeah, blood no. হাতটা কোথেকে নেবে? হার্ট পাংচার করবে? হাত তা হাতে কোথেকে নেবে তুমি? হাতে তো পাওয়া যাবে না গো। হার্টে পাংচার করা হয়, হার্টে পাংচার করা হয় না তা না, হার্টে পাংচার ওষুধ দেওয়ার জন্য আমি নিজে দিয়েছি, আরে নিউবর্ন বেবিকে দিয়েছি, মরে গেছিল বাচ্চাটা। তো মারা গেছে, ইমিডিয়েটলি আমি ডেড বডি বার করেছি, নিজেই বার করেছি, ডেলিভারি করেছি। তার কর্ড রাউন্ড আর নেক ছিল, কেউ ছিল না। সকালে 6:30টার সময় বাচ্চাটা হয়েছে, আর বাচ্চাটা একদম পুরো লাইভ বেবি। আমি দেখলাম পরিষ্কার বাচ্চাটা রয়েছে, একদম পরিষ্কার জ্যান্ত। কর্ড ক্ল্যাম্প করলাম, বেবিটাকে টানলাম, ব্যাস বেবিটা ডেড। মাকে দেখালাম, বাচ্চা কিন্তু কাঁদছে না। Terrific situation. Only thing that I had an idea in physiology class that epinephrine can be given. Epinephrine is given in the heart. What I did immediately, I took the baby to ask the sister. Sister, you please take the baby to room. Please rush simply. Use a sucker, and I drew 1 ml of adrenaline injection and gave it directly intracardiac. I simply punctured at the pericardial site and drew the blood and injected it, and heart started beating. Baby was at least alive. Only problem is what I could not understand, that I perhaps could made some amount of damage. Baby was alive, no doubt, but there is a time lapse. See, no clapping. There will be abnormal situations which you will face in your life. At that time, you have to use your own brain. See, giving a dead body to a mother is a painful condition, I am telling you. When a baby has been born as a fully alive term baby, cord round the neck, and it caused asphyxia during delivery, and I have conducted it. After clamping it, the baby was not crying. During my intensive it happened. Nobody was around, no senior person was there. So I used my physiology class, physiology knowledge, and gave an intracardiac injection of 1 ml only. Heart started pumping, the respiration was restored. During that time in 1986, there is no such type of advanced facility was there. But at least I am happy that I could give a mother a live baby. It's a very pathetic condition if you deliver a baby and give a dead baby to a. That's what I am telling. Every biochemistry knowledge, every knowledge, whatever you are having here, not only for this CSF class, but again I am telling you there is a severe ascites in one patient, and it is not written in the medicine book that this type of therapy is given. Then I told my sister that you give albumin level was so low, and because of that fluid was accumulated in the abdomen. I told her that your brother might be basically physician, he will not allow this in this procedure, but I am suggesting that procedure, what is written in the book, it will be taking 6 months time for the ascites to go. But if I tell you the method, this entire fluid will go in 3 days time, and your mother will walk in 1 week's time. What I did, albumin level was low. I told him that he transfuse human serum albumin. That 3 bottles of human albumin was given. Because where from I got the knowledge? I knew the knowledge because of biochemistry, and that I applied on a patient. So therefore, whatever classes you are taking, and in 3 days time with 3 bottles, the entire fluid collected in the peritoneum fluid simply passed away through the urine. That's the purpose I am telling you. See, so everything is important. Whatever you are learning, try to make an application wherever you will get a chance. So collection of CSF, this is I am telling you this from the baby. See, there is no route but to take a lumbar puncture. See, from the femoral vein. Now, can anybody tell where the femoral vein is located, whether it is medial, lateral, inferior or superior to femoral artery? Because you have to ultimately locate it. Where it is located? It is superior to the femoral artery or inferior or medial or lateral. And that you must be able to tell at this stage. That is what I want also expect. You have been told about inferior extremity. Have you not been told about the anterior triangle? What are the structures under the? I am not asking the anatomy question. I am asking a very simple question: where the femoral vein is located? Femoral artery, yes, femoral artery. Laterally. Lateral to femoral artery or lateral to medial? কোনটা ল্যাটারালি আছে? আর্টারি ল্যাটারাল আছে, ফিমোরাল ভেনটা? আমি জিজ্ঞেস করছি ফিমোরাল ভেনটা কোথায় আছে? ফিমোরাল আর্টারিতে না ফিমোরাল ভেন? ফিমোরাল আর্টারিটা মিডিয়ালি আছে না ল্যাটারালি আছে না? মিডিয়ালি আছে। সবাই এগ্রি করছো? মিডিয়ালি, ফিমোরাল ভেন মিডিয়ালি আছে। তাহলে ফিমোরাল আর্টারিটা ফিমোরাল ভেনটা ট্যাপ করবে কি করে? ফিমোরাল আর্টারিটা পালসেট করবে এখানে, ঠিক একদম ফিমোরাল ভেনটাকে করলে পালসেট করলে এখানে, এইবারে আঙুলটা যেটা রয়েছে আঙুলটার পাশ দিয়ে পুরো নিডলটাকে পাংচার করবে, নিয়ে একটু টানবে, তার নেগেটিভ সেকশন দেবে, তাহলে ফিমোরাল ভেন থেকে ব্লাডটা পেয়ে যাবে। So if you want to collect a larger sample of blood, sisters will not do it until unless expert, but as a doctor you have to do it. So that you must know the total full anatomy of that particular place, and you must be able to puncture get only a single chance. You cannot puncture doubly to a baby, particularly newborn. Remember, that's a very dangerous procedure. And accidentally, if you prick femoral artery, that will cause catastrophic result. I'm telling you, that was total, hematoma. But anyway, that's not the class for femoral artery tapping. So how will you collect CSF? That I have shown you the picture. Why lumbar puncture? Huh? L4, L3, L4. Why from L3, L4? Yes, correctly told. L1 spinal cord surgery, lower border stress হচ্ছে, ঠিক। L3, L4 কি করে ডিটেক্ট করবে? How will you detect L3, L4? হ্যাঁ? Iliac crest থেকে, আর highest point of the iliac crest is the landmark. Okay, so what you do basically, you allow the body, the spine to a little bit curve, drag the patient to the side of the table, you sit down on a stool, and you draw a line from highest part of the iliac crest. It will exactly locate between the L3 and L4 vertebral interspinal space, and that is the identification point for L3, L4. Why? Because spinal cord is ending at the lower end of the L1 vertebra. So we have to leave one space below, because if by chance the spinal cord ends somewhere down below, there is a high chance that you are likely to puncture that subordinate spinal cord. To avoid that thing, either you choose L3, L4 the most preferred place, and from where it is collected. L4 and 5 also you can collect, but that you may not get that adequate amount of fluid. The amount of space is here. Only thing, remember, it is just like a surgery. It's all aseptic precautions have to be taken, because if you do not take it, if the patient is not infected, through needle you will introduce infection into the spinal cord, and that will cause meningitis. Remember. So therefore, be very particular about aseptic precautions. Not only with a normal needle, but you require a lumbar puncture needle, that is a special needle that is sterilized. All materials are sterilized by inserting between the interspinal space L3 and L4 vertebra. Of course, for baby size will be different. For young child, the size will be different. For adult, there is a separate size, special size, and these are available. And we draw, if you puncture it here and the CSF is not in normal pressure, then it will come and drop wide. Remember one thing, before doing any lumbar puncture, you have to ensure there is no intracranial tension. Because if there is a high intracranial tension, and if you puncture it, fluid will come in jet, and there will be sudden fall in the pressure, cerebrospinal special pressure, that will cause herniation of the brain, and you might lose the patient during this procedure. That you must ensure. So if once you puncture, it will come dropwise. There is a possibility that during this puncture, there is an accidental prick in the, because you are doing it in blindly. Once you do this thing, at least first time, you will remember that this needle will go very smoothly. Through a hard structure, through the ligament it will pass. Then at one point of time, you will feel the cartilage. It will hit you will get a good amount of resistance. Once you puncture that thing, it will give way, and the needle will go inside the spinal space, subordinate space. And from the moment it goes, you can see from the other side, this coming dropwise. And you have to collect in 3 samples, 3 bottles. One will go for biochemistry, one will go for pathology, and one will go for bacteriology. By chance, particularly for babies, you cannot draw 6 ml of CSF. No, not permitted, because their volume is so low. In that case, if you draw 2 ml of blood, please inform the laboratory that we could not draw more than this. This is a baby. So they will try to do this analysis with that amount of blood. Okay. And while you are tapping, you will be able to diagnose the case what it is. That's the purpose of this today's class. So what will happen after you do the lumbar puncture? Since you are drawing 6 ml of blood out of 125 ml, so there will be sudden reduction in the pressure, and that will cause post lumbar puncture headache. That's why as a routine, the patients are allowed to lie down at least for 4 to 6 hours, because CSF will be formed at the rate of 0.5 ml per hour. So to replenish that, it will take about, if you allow them to at least quietly lie down on the bed, at least 3-4 ml CSF will be formed by that time. Remember, CSF is a very infectious material. You have to handle it carefully. You don't know what type of infection it is. So indications for lumbar puncture, main is meningitis. And in fact, I am telling you, in Bardhaman Medical College, there is a basically encephalitis ward during the outbreak post-rainy season. And I have done almost 100 of cases of LP during my internship period. Because every case needs to be ruled out whether it is an encephalitis or it is meningitis. That was the basic purpose. So we have done a number of LPs, and you need practice. Otherwise, there will be dry tap. You will not be able to insert the needle. You will not get the fluid. So that requires practice. So whenever you will find an opportunity, do an LP yourself. So basically, the purpose is viral, bacterial, and tubercular. And in resource poor setting, you will not get a CT facility. Now today, because of the advent of the CT facility, you can diagnose whether there is an intracranial hemorrhage or not. But in resource poor setting, even if you do work in a hospital, there are not 2 CT scans. Maybe you will get one CT scan, like something. It might go out of order. Patient is admitted. What will you do? And you suspect that this is the case of subacute hemorrhage, and you have to confirm it. So for that, you require a LP. And a characteristic finding will be found in subacute hemorrhage, which I will show it to you. Brain tumors, of course, can be diagnosed today by CT scan or MRI, better MRI. But again, for some tumors, will be requiring what type it is, what was the actual cause, particularly for immunological infection and other CNS infections, particularly Guillain-Barré syndrome. Guillain-Barré syndrome cannot be diagnosed radiologically. I am telling you, it needs to be diagnosed by biochemically, confirmation. Clinically, you can suspect, you will have a good suspicion, there will be paraplegia, both legs will not be moving. In fact, I have seen one case during my internship again, one lady, I will sustain the Guillain-Barré syndrome, both legs were paralyzed, her husband was not willing to take her back. It's a very pathetic condition. So, again I repeat the same thing, you remember this thing, this line if you want to write down also. CSF comes in contact with the perivascular space around the blood vessels entering and leaving the brain, from where cells and protein leak during inflammation. Or if there is an obstruction to the CSF flow, that brain tumors and other neurological diseases. And in CSF, albumin is the predominant protein. So globulin is also present, but in the less high concentration. If there is a marked increase in the permeability, particularly for chronic diseases, tuberculosis, it doesn't occur in overnight, unlike bacterial or viral and meningitis. So that causes progressive damage to the, that meninges, and it increases the permeability. That's why fibrinogen with a molecular weight of 350 kilodalton also comes through, and the fibrin makes a clot, a characteristic clot for tuberculosis. And you will be able to diagnose if you keep the fluid overnight, about 12 hours. That picture I will show you also to you. So as I told you earlier, usually 2 ml is collected in each 3 tubes. One is sent for biochemical, glucose and protein. One is cytological for cell count and cell type. And third one is bacteriological, because if you want to see the bacteria, presence of bacteria, whether it is a bacterial, pure bacteria or a microbacteria. Okay. For that, we have to identify the bacteria through microscopy, and culture sensitivity will be required because you have to choose the proper antibiotic. Once you diagnose, you start empirical treatment on meningitis. Whatever be antibiotic available. In our days, penicillin was available. Penicillin. Now today we are not using penicillin. Ceftriaxone is used. You start ceftriaxone and then you wait for the culture sensitivity report. Then you select the proper antibiotic. That's the purpose. So biochemical investigation, remember this is a priority investigation, just like hypoglycemia. If you suspect any hypoglycemia, you can do it glucometer, or if you want to reconfirm it, send it to the laboratory under request. So the laboratory will take the sample out of turn and make it as a first sample to be analyzed. So CSF sample has to be done on priority because you require a diagnosis immediate, and secondly, CSF glucose level will fall if you allow it, because bacteria will be there, the neutrophils will be there, and they will consume the entire glucose. Whatever is present, small amount of glucose, and it will bring down to zero also. So there will be erroneous interpretation also if you don't do it on priority basis. So simply inform the laboratory. And since you will be doing the biochemical investigations, the sample has to be centrifuged fast because it will contain cells. So the cells needs to be deposited. And if there is a clot also, that clot needs to be deposited. We want a clear fluid for analysis. So CSF analysis, glucose is done. That is the GOD-POD method which you are doing for the blood glucose level. Because you see the sensitivity blood glucose level you have seen, what is the range? 40 to 60. So that will be present, and for normal age ratio, as I told you, it is 3:1, and serum procedure is 2:1. And protein estimation is done by the sulfosalicylic acid method. Just remember this thing, this is the cheapest method. Even today, at DSP hospital, we are doing the same procedure. Of course, sulfosalicylic acid, there is a kit method also available that is being done everywhere, wherever you go. Even in this hospital, perhaps this kit method is used. There is a uniqueness of this kit method. It is simple that pyrogal red is there. This method, sulfosalicylic acid, is just like protein, urine protein. You add, if there is a protein, if you add sulfosalic acid, it will cause turbidity. Same thing will be true for CSF. So it will cause the turbidity, and you measure the turbidity in a colorimetry. This CSF protein is a pyrogal red. That forms basically a colored complex with the CSF protein, and the absorbance is proportional to the concentration of that protein. That's the simplest thing. And you can see the protocol. I am telling you, in your experiments, you have used one standard. But if you want to have a sulfosalicylic acid, you require a multi-standard curve. So it ranges from 12.5 to 100, basically from 0 to 100 milligram per deciliter. Now you analyze the sample and you get a result somewhere here. You plot this result like this. You will get the reading here. This is a very stable curve. 30 years back, 31 years back, when I joined, this curve was drawn, and I cross-checked with the human serum albumin. These results are very stable. So we are using the same standard curve. So that is the simplest thing. The only limitation here, you can cover only up to 100. And if sample is higher than that one, that requires to be diluted and it has to be multiplied. Like I modified the technique because the CSF sample is a little very precious. You cannot get it twice. So I have, in the initial phase at least, I have diluted the sample. So I will get at least up to 200 milligrams. So because we multiply it by 2. This is the modification which I made after joining. Again, the pyrogal method, the same procedure. You make a reagent of 1 ml, you add distilled in blank, standard 20 ml, the sample 20 ml, and allow the just like glucose procedure. Wait for 10 minutes. Take OD reading at 600 nanometer, total concentration. OD test by OD standard into concentration standard. The linearity here is most important part is 20 to 3000. That is the main difference between sulfosalicylic and this one. The only thing is that every time you need to do this test repeating. Not only you cannot do a single curve using that curve. That's another point. But usually with that figure up to 200, we can diagnose most of the cases. The test for globulin, this is just to remember the name Pandis test. For globulin, in future, if you require any globulin to be analyzed, you ask for Pandis test. It is just an addition of phenol and water and 2 drops of CSF. You give degree of population just like turbidity. And marked populations, remember marked populations, this is done only in case of multiple sclerosis. Now this type of cases is not found nowadays. not that much nowadays. It's usually done in the neurological setup. Now come to the main point where you have to concentrate absolutely, because at the end you have to answer this question. See, normal appearance, clear, transparent and colorless. Normal appearance will also be found in viral meningitis. Turbid appearance will be characteristic feature for bacterial infection, bacterial meningitis. And cobweb coagulum, although it requires standing for 12 hours, not done nowadays, but in a resource pure setting, you have to diagnose, you take the sample, wait for 12 hours, or keep it overnight. If it is a tubercular one, you will find a cobweb. Cobweb means ঝুল, না মাকড় সাইজ ঝুল, এটা মানে ঝুলের মধ্যে স্ট্রাকচার দেখতে পাবে এবং এটা তোমার দেখতেই পাবে। আর একটা কি না রেডনেস, হেমারেজ পাবে। যদি অ্যাক্সিডেন্টালি প্রিক করো তাহলে একটা হেমারেজ হতে পারে, সেটা ইনিশিয়াল ফ্লুইডে পাবে। ইনিশিয়াল যদি স্যাম্পলগুলো যদি আসবে সেটা দুটো তিনটেতে হয়তো একটু রেড ব্লাড সেল পাবে, কিন্তু তারপরে কিন্তু ক্লিয়ার সলিউশন পাবে। সো ওই রেড সলিউশনটাকে পাঠাবে না কিছুতেই, এটা বাদ দিয়ে দেবে, মানে ফলস ইয়ে হয়ে যাবে, ডায়াগনোসিস হয়ে যাবে সেরিব্রাল হেমারেজের মতো। বাকি যেটা ক্লিয়ার পাচ্ছ দেখতে চোখে সেই স্যাম্পলটা পাঠাবে, আর অ্যাটলিস্ট বলে দেবে যে একটা অ্যাক্সিডেন্টাল পিক হয়েছিল, তো ইনিশিয়াল স্যাম্পলটাতে হয়তো দুটো রেড সেল চলে আসতে পারে, বলে দেবে ল্যাবরেটরিতে, কিছু অসুবিধা নেই। তো ইট ক্যান হ্যাপেন, উই নো, তো ইট ক্যান হ্যাপেন। Xanthochromia, that is yellowish discoloration, presence of bilirubin, and that is a characteristic feature of subarachnoid hemorrhage. In fact, I diagnosed a case in Bardhaman in 1986 against subarachnoid hemorrhage by Xanthochromia only. On the next morning, I did this CSF. Clinician wanted, HOD wanted that what investigation will answer CSF puncture, do it. And I demonstrated, I mean, visually one can detect the CSF because yellowish in color. So that made a confirmatory diagnosis. So blood in CSF will be having, depending on the type of bleeding what happened. Particularly this type of case you will get in the first sample if you make an accidental prick. But if there is a real hemorrhage, you will get a CSF like this. Of course, this type of blood means full of blood. And this is yellowish discoloration, that means this is Xanthochromia. Presence of bilirubin is there. Blood is there, but that blood has been converted into bilirubin. Because it's a subarachnoid hemorrhage, so hemorrhage will be there. So what is Xanthochromia? That is basically a lysis of RBC from where heme will be released and will be converted to bilirubin. And for which, that's why you have to require at least 12 hours time. Once you suspect that this is a case of subarachnoid hemorrhage and you want to reconfirm it, if you don't have any CT facility here or anywhere, if you want to, that you please wait for, start the treatment, but wait for 12 hours at least overnight. Next day you puncture LP and you will get this type of picture depending on the degree of hemolysis. If you get a little hemolysis, then you will get little Xanthochromia, and this type of Xanthochromia also, and Xanthochromia CSF is also, because if the hemorrhage amount of is very high. So Xanthochromia is a characteristic feature of hemorrhage, particularly subarachnoid hemorrhage. One, this you must remember, as I told you, albuminocytological dissociation. See, there will be situations where the CSF protein will be abnormally high, but the cell count will not be proportionate, so there will be disproportionate rise in the CSF protein. So elevated CSF protein level in the relative absence of CSF leukocytosis is hallmark of Guillain-Barré syndrome. There is no other way to diagnose, confirm the case. In the acute phase, basically, the characteristic finding will be CSF will be protein without any elevation of white blood cell count, because there is no inflammation. So that's the characteristic feature of Guillain-Barré syndrome. Second, you just concentrate here, this normal viral meningitis, if you see, this will get a clear fluid, or if the duration of the disease is a little high, then only permeability will be a little bit higher, so you might get a slightly cloudy, turbid type of solution. That is the characteristic feature of viral meningitis. So while you are drawing the sample, from the appearance you will have a suspicion, only thing you will have a confusion between this thing and the bacterial meningitis. The bacterial meningitis present, if they present is a little earlier, you will get almost a similar type of result. Now, what is the finding of viral meningitis? That you concentrate here, at the end you have to answer the question. See, appearance will be clear or colorless, or it may be slightly turbid. Maybe, if it is of longer duration. protein will be normal or slightly increased. It will not exceed usually more than 100, or it will be average 20 to 80, not more, much more increase, because that not much more inflammation is there. Glucose will be almost normal because there is hardly any cell, because this cell number is also very less. They won't be able to consume. Virus doesn't consume that much amount of glucose. So cell count will be basically typically 20 to 500. Of course, whatever picture I am giving, that is based on just for your understanding. From case to case, it will vary. If the severity of the case is high, obviously you don't get this type of classical picture. This is for your understanding. I have made it very simplified. And the cell type will be basically lymphocytes, predominantly. Suppose if infection is there, on top of which bacterial infection has occurred also. So you will get a mixed type of thing. So don't get confused. At this stage, I don't want to make you confused also. Have a clear-cut idea that a clear case of viral meningitis, you will have a mostly lymphocyte, and the typically cell count will be 25. Glucose will be almost normal, and CSF protein will be normal or slightly increased. But coagulation is normally not done. That coagulation study, that will be nil. So bacterial meningitis, it will be invariably turbid, I repeat, because there will be leukocytes, there will be pus cells. So the moment you puncture, you will find a fluid which is turbid, make a provisional diagnosis itself that this is a case of bacterial meningitis. And depending on the degree of infection, you can see this type of color, and you can see this is a frank pus. Means the infection is very severe. And the amount of blood, you can see whatever blood is there, perhaps you have accidentally pricked it. That sample was pricked, but that is not going to, make any wrong diagnosis because it is full of pus. No other practical investigation is required. Only by seeing the color you will be able to diagnose. So as a clinician, while you are doing this CSF analysis, after you complete this class, you must be able to diagnose on the spot itself what type of meningitis you are handling. And if you do not do it, perhaps again I will tell, I have miserably failed in teaching you. Findings in bacterial meningitis, color will be opalescent or turbid as a rule, it will never be clear. Protein will be marked increased because the degree of inflammation will be high. The glucose will be decreased markedly because bacteria will consume that amount of glucose, and that is where it is a priority sample. So if you draw the sample while the sample is sent in front of the laboratory, so on priority immediately in 0 minute time, the sample will be centrifuged and it will be analyzed. So if you allow more time, or if there is a severe infection, glucose will be 0, level will be 0, and I have found it. 0 blood, CSF, 0 glucose in CSF sample. And the fluid was just like a turbid. I told them, if you analyze the sample, perhaps you will get it 0. And you must expect that thing also. What WBS count will be very high, 1,000 to 5,000. And since this is an infection, there will be polymorphonuclear leukocyte infiltration, where they will try to engulf the bacteria and try to prevent the infection, try to control the infection as much as it can. So therefore, it will be mostly polymorphonuclear, and neutrophil count will be more than 100%, 80%. Coagulation, definitely it can clot on standing, provided there is adequate leak and there is a fibrinogen also is present there. So CSF glucose concentration is very low. CSF glucose concentration, serum glucose ratio, as I told you, if there is a diabetic patient, if you see the glucose level is high, at least do a simultaneous blood glucose level, and if the concentration is less than, the ratio is less than 0.6, you can see it, because you see I have shown here, the glucose level will be decreased markedly. Again, I am telling you, if you get 100 glucose level, maybe the person is having 400 fasting blood sugar level, or 300 fasting blood sugar level. That you must remember. It can be less than 0.5. If it is 0.4, you just make a provisional diagnosis. If it is less than 40, I am telling you, less than 40 glucose, if you get and make a provisional diagnosis, that it's basically bacterial meningitis. That will be possible, or when there will be confusion of turbidity. Because in the tubercular and viral and bacterial, there will be confusion if it is in a mild case. In that case, this is that will be suggestive. It can be seen also in fungal, bacterial, tubercular, carcinomatous. The carcinomatous cells, that will also consume very high amount of glucose. Because all cancer cells are metabolically active, they consume glucose at a much faster rate than the normal cells. So one thing I told you that it takes about 30 minutes time to several hours for the concentration of CSF glucose to reach equilibrium with the blood glucose. So whatever blood glucose you will, CSF glucose you will find today right now will not be the same. It will be reflecting the blood glucose level 4 hours back. So until and unless the patient is given any, I think high glucose, glucose fluid or any food which contains, which can raise the blood sugar level, blood glucose level, then only it will be almost that 0.6%, that ratio will be applicable. কোনটা বলো 87%, এই যে 87% এই পলিমরফোনিউক্লিয়ার লিউকোসাইট, এই যে 87% কেসেস পাবে মোটামুটি যে 80 in if you analyze 100 cases, suppose in 87 cases 7 cases you will get this type of picture. So see range is, you see 100 to 5,000. This I have taken from your book because you will be reading the book, but again it can go up to 10,000, even more than that. If the infection is very severe, this is a gross idea just to give an idea as to what will be the approximate result. But again, depending on the severity, it can be 20,000, it can be 25,000. You don't know. Even it could be as low as, here I have written 100, it might be 90 also. It might be 80 or so if it is present a little early. It depends entirely on the degree, but it is not usually less. It is usually always you will get a more count. Always you will get a more count. Because the patient will not come on the same day. He will wait for 1 or 2 days time. At least fever is not receding. There is some symptom of headache, some neck rigidity, some problem is there. That's why he will present at least after 3-4 days. By that time it will not be 100. He will get more than 100 cells. So tubercular meningitis, again this will be almost cloudy. Characteristic feature, as I told you, it will be cloudy slightly. And the cobweb coagulum, this will initially form a network like this. And if you keep it overnight, you can see this type of collagen structure. And it might, if it is very high amount, then you can get a almost full clot. That you will be able to visibly see. And in any setting, wherever you get a chance that you can collect a little more fluid, want to collect for yourself. Keep it overnight. And in the next morning, you come and see. And next day also you see whether a coagulum is there. Try to see the total protein level also. Please go to the laboratory because laboratory manipulates. I have seen one case, 5,000 report I got of total protein and make it a black diagnosis that is a case of tubercular meningitis. Forget about other results. I don't care for this thing. That is a case of tubercular meningitis because 5,000 milligram per deciliter protein cannot occur in normally in bacterial meningitis. The biochemistry and glucose level was normal. So what will be the finding in tubercular meningitis? It will be clear opalescent. Protein will be increased markedly, remember. That is one characteristic point of tubercular meningitis. Glucose will not be that much low because tubercular bacillus doesn't consume that much amount of glucose unlike bacteria. Cell count, again I am telling you, it is not basically high, it will be less than 500. That's why glucose level will also not be low that much. A cell type again is a predominantly lymphocyte because this is a cell-mediated immune response type of infection. So you will get mostly lymphocytes. And again I told you, coagulum, this is not done routinely. But as a clinician in resource poor setting, you can do it, keep it overnight standing more than 12 hours, you can find it. I mean, out of say 100 cases, you might find in 10-15 cases. But once you see this thing, you will never forget. Okay, now come to this is the main comparison chart. Just like there are 3 types of jaundice that you must remember throughout the rest of your life. And remember that this was taught in your biochemistry class, and from this class itself, you will be able to diagnose this case properly. Okay, that's what I have told. That is exactly written in a tabular form. Okay, this is the almost end. This is the actual end of my own lecture. Now I am coming to you. This at the end, you will do the investigation. Now you have to diagnose. Now I am going to you. Just someone of you just come. Hello. You are concentrating too much on mobile. Please come and teach us. Come. চলো ভাই, আর কিছু করার রাস্তা খোলা নেই তোমার কাছে। আমি হাজারবার বারণ করলাম, আমি বললাম, তবু তোমরা মোবাইল ইউজ করলে। যাও, চলো ক্লাসে পড়ো, তোমাকে পাস করাতে হবে আমাকে। হেডেক আছে তোমার চেয়ে, আমাদের হেডেক কম নেই কো। এত বাজে রেজাল্ট করেছে, সমস্ত অ্যাকাডেমি হেডের সাথে কথাবার্তা হলো, ফিজিওলজি হেডের সাথে কথাবার্তা হলো। যাও তোরা, এত এবারে পরীক্ষা পাস করাটা খুব সোজা হবে না গো, চলে যাও ওখানে, যাও ওখানে বলো, যাও এখানে বলো, এক্সপ্লেন করো কি, এদিক ওদিক করবে না, দেখা বলে ওখানে যাও, আমি এখানে বসছি, যাও ওখানে সামনে যাও, দাঁড়াও। এত কনসেন্ট্রেট করছো মোবাইল নিয়ে বসে বসে। এই রিপোর্টে বলো কি রিপোর্ট, সারাক্ষণ ধরে কি শুনলে ক্লাসে, এতক্ষণ যে বকলাম আমি। দেখো তোমাদের বন্ধুরাই বলে দেবে এটা ডায়াগনোসিস কি আছে। Can anyone will volunteer whatever meningitis it is? She told bacterial. Anyone is at the counter? You have to tell this thing. There is no escape. At least I will not leave this class until all the classes are this. I mean, all of you have understood. She at least told voluntarily. At least I am happy. At least she told. What is the diagnosis? How many is in favor of bacterial diagnosis, bacterial meningitis? বলো হাত তোলো, হাত বড় করে তোলো তো। 1 2 3 4, তুমি তো আধখানা তুলেছ, ঠিক করে তোলো, গোটাটা তোলো, আমি দেখতে পাবো কাউন্ট করছি। 1 2, তুমি তো আধখানা তুলেছো, তোমারটা শোনা হবে না, তুমি তো নাকটা এখনো ঠিক নাই, কিন্তু তুলেছো, দেখো হাত 1 2 3 4 5 6 7 8 8, তোলো হাতটা তোলো, 8, ঠিক আছে। সবচেয়ে আগে বলেছে তুমি এদিকে এসো, মোস্ট ওয়েলকাম, ইউ হ্যাভ টোল্ড কারেক্টলি। দেখো তোমাদের মধ্যেই বলতে পারছে, শুনে যে ক্লাসটা প্রথমে ওই বলেছে, and I want that every one of you must tell simultaneously. না ওখানে দাঁড়ানো, তুমি এসো, টিচার হিসেবে এসো, to play the role of a teacher. You can teach, you have that capability. I'm quite happy to come. Explain. হ্যাঁ, গ্লুকোজের চেয়ে আগে দেখো, তোমাদের বারবার বললাম না, শুধু কালার দেখে বলতে পারবে, ব্যাস ওখানেই ডায়াগনোসিস হয়ে গেছে, ব্যাস ওটা ডায়াগনোসিস হয়ে গেছে। এবারে দেখো, হ্যাঁ গ্লুকোজ ঠিক ফার্স্ট ক্লাস বলেছো, খুব ভালো বলেছো। দেখো ওকে পয়েন্ট দেখো, একদম খুব রাইট জায়গাতে পয়েন্ট করেছে। সেল কাউন্ট কোথায় আছে, ও তো দেখো একটা ঠিক ভালো বলেছে, একটা পয়েন্ট প্রথমেই ধরে নিয়েছে, গ্লুকোজ লেভেলটা দেখেছে, তাকিয়ে দিয়েছে, তার আগে ভালো পয়েন্ট বলে দিয়েছে, শুধু কালারটা দেখো। তোমাদের বললাম যে এলপি করার সময় তোমরা ডায়াগনোসিস করতে পারবে, বাকি আর কিছু করার দরকার নেই। তো ওই টার্বিডিটি যখন দেখতে হয়, হোয়াইট দিস ইজ ব্যাকটেরিয়াল মেনিনজাইটিস, pus cells are the neutrophils are there, that's the color white, pus cell will be there, neutrophils will be there, and that has consumed the bacteria, has consumed the glucose. That's why the glucose level has come down to 10. What about the protein level? It has not increased markedly. You can see the 100 milligram only, but in contrast you see the cell count. It is not in 100, it is 1000. And again, neutrophil, why neutrophil? Because neutrophils are trying to engulf the bacteria to control the infection. Wherever there is a bacterial infection, usually neutrophils come into the picture. Wherever there is immunological reaction, lymphocyte will come. Remember, make it a point. The lymphocyte will be high in case of viral, in case of immunological disease. But neutrophil as a routine for the bacterial infections. Thank you. তুমি মোবাইল ফোবাইল ঘাটা বন্ধ করে ফেল করবে, আর এবারে ফেল করলে দ্বিতীয় বাচ্চার সাথে বসতে হবে, রুল করে দিয়েছে, বলতে বাধ্য হচ্ছে, কিছু করার নাই, কেউ বসে কেন চুপ করে। এইটা বলো, কে বললো ভাইরাল, তোলো হাত তোলো, হাত তোলো, ভাইরাল 1 2 হাত তোলো, 1 2 3 4 5 6 7 8 9 10 11 12 13, চলো এদিকে তুমি এসো। খালি পায়ে চলো না রে বাবা, কিছু হবে না এখানে, এমন তোমার কেউ দেখতে যাচ্ছে না, চলো। দেখো এতগুলো ছেলেমেলে ভাইরাল বললো, দর্শচক্রে ভগবান ভূত কিরম হয় দেখো এবারে। যাও চলো, যাও 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 যাও, আবার তুমি তোমাকে বলে জিজ্ঞেস করি না, চলো। যা ভাইরাল তো তুমি বলে দেবে দুম করে, এতগুলো লোক বলে 90% লোক বললে ওই রাহু গ্রাস করছে চন্দ্রকে, সেই জন্য চন্দ্রগ্রহণ হয়। যাও গে বলো, যাও গে বলো, আগে যাও, আগে দাঁড়াও, এরকম করে না বললে হবে না, ডাক্তারি করতে হবে বাবা মা। তুমি আগে চলে যাও, ভোটার কাছে চলে যাও, ভোটার কাছে যাও। আই এম ট্রাইং টু টিচ ইউ, ডোন্ট ফরগেট, every one of you have to interpret the report. I repeat, at the end of the class you must be able to diagnose properly. That's the purpose of this class. No patient will listen to what is how the CSF circulates, all this thing, where it is produced. But doctor report নিয়ে আসি, বলুন কি ব্যাপার। এখন এটা চেঞ্জ করে দিলে ভার্সন, এখন বিজেপিতে ছিল, এখন তৃণমূল হয়ে গেল নাকি? সরি, পার্টটা কেটে দেবেন, এটা স্লিপ অফ দ্য টাং হয়ে গেল, এটা পার্টটা কেটে দেবেন না, ঠিক আছে? পলিটিক্যাল স্টেটমেন্ট সব না করা। দেখো তোমরা ভার্সন চেঞ্জ করলো, কে কে নর্মাল বললে আবার হাত তোলো। 1 2 3 4 5 6 7, 7টা বাকিরা কোনো রেসপন্স নাই, মানে তার নির্দল বা চল মানে জবকে ভাব দেখে দেবো। আর ঠিক করে বলো, কে বললো ওই দিক থেকে? তুমি হাত তুলেছিলে না? তুমি হাত তুলেছিলে? হ্যাঁ, তুমি ওইদিকে বলো। দেখো তোমার এই বন্ধুরা বললো তো, বসো, তুমি শোনোই নেই কিছু ক্লাসে। একটা লোক ওই যে ঠিক করে বলে কোনো সত্যি কথা, আর সেটাই রুল, মনে রাখবে। মাস কোনোদিন সত্যি কথা বলে না, পৃথিবীকে কেন মাস চেঞ্জ করতে পারে না, মাসকে চেঞ্জ করে দুটো একটা লোক, বাই টেলিং দ্য ট্রুথ। বলো, যাও বলো 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 বলো, আই ওয়ান্ট টু হিয়ার ফ্রম ইউ। যাও 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 যাও, এক্সপ্লেন করো, আমি শুনছি। হ্যাঁ ব্যাস, ঠিক আছে, ভালো। আর যাও ওখানে যাও, তোমার রেকর্ডিং হচ্ছে তোমার। আই ওয়ান্ট টু সি দ্যাট রেকর্ডিং মাস্ট বি প্রেজেন্ট। কবে কখনোটা করাই হয়নি, বারবার বললাম যে কবে কবে নর্মালি করে না, বাট কথা বললাম তো, বায়োকেমিস্ট্রি ইয়ে দেখি বলে দিতে পারবে। হ্যাঁ, প্রোটিনটা কি আছে? নর্মাল আছে, নর্মাল তো প্রোটিন নর্মাল কত থাকে? কত থাকে বললাম প্রোটিন, কেউ বলতে পারবে নর্মাল প্রোটিনটা কত থাকে লাম্বার রিজনে? 15 থেকে 45 বললাম না লাম্বার রিজনে। ওই লাম্বার রিজন থেকে যেহেতু করি আমরা কনসেপ্টটা, সেই জন্য লাম্বার রিজনটা মনে রাখবে, অন্য রিজনগুলো তো মনে রাখবে না, জাস্ট আমাদের জানানোর জন্য বললাম। সো প্রোটিন ইজ অলসো উইদিন নর্মাল রেঞ্জ। হোয়াট অ্যাবাউট গ্লুকোজ? হ্যাঁ হ্যাঁ, তো 60 আছে, 100 থাকতে পারে, তার 60 করে দেয়। ওকে, হ্যাঁ তো ঠিক আছে, কোনো অসুবিধা নেই গো। পেশেন্টের যদি ব্লাড গ্লুকোজ 100 থাকে, 100 110 করে থাকতেই পারে, তার 60% সেলটার দিকে দেখাও। এইটাই যদি এরকম কেস তোমরা পাবে মাঝে মাঝে, তো ডাক্তার রিপোর্ট কি বুঝলেন? নর্মাল। কারণ তাহলে আমার এলপি কেন হলেন আমার বাচ্চাটা? এই কোশ্চেনের আনসার কিন্তু দিতে হবে। Be very careful while you are doing an LP. You have to make a professional diagnosis. Don't make any LP unnecessarily. In many situations, you will get a normal report, and that will happen only when there is meningism. Remember, meningitis is like of structure, but you are not sure, and that's why you have done it. Now, at least you will explain when you will get this type of result. At least that patient is not having any meningitis. Thank God, we got a normal report. That's how you have to damage control exercise you have to make to save yourself, to save your colleague also. ঠিক আছে, করে ফেলেছে মনে হয় সন্দেশটা, আজ কম সময় রিপোর্টটা তোমার নর্মাল আছে। অ্যাটলিস্ট পেশেন্টের মেনিঞ্জাইটিস তো হয়নি, বাঁচা গেছে, বিরাট বড় রোগ হতো, অনেক ভয়াবহ করে বলতে হবে। এরকম পাবে নর্মালি কেস, এরকম পাবে। যা বসো। দেখলে তো এতটা বলার পরে একটা নর্মাল রিপোর্ট তোমরা বলতে পারলেন না, তো নর্মাল রিপোর্ট ইন্টারপ্রেট করতে পারো না, কতটা খারাপ লাগছে আমার নিজের বল থেকে। এতক্ষণ ধরে বললাম বসে বসে। বলো, এইটা বলো। হাত তোলো। 1টা 2টো 3টে 4টে 5টা 6টা। বাকিরা? তুমি তো কিছুই বলছো না, তুমি কিছু বলছো না, তুমি কিছু বলছো না, তোমরা কিছু বলছো না, আমি তো মুশকিলে পড়ে গেলাম। তুমি কিছু বলছো না কেন? তুমি চলো এখানে চলো, ওটো 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 এদিকে এসো। তুমি ব্যাকটেরিয়াল বলে চলো, ওখানে যাও, তুমি শুধু যাও, যাও তুমি যাও, তুমি চলো। ট্রেন বাড়ি চলে যাও, তোমাকে কে তোমাকে রেখেছে? তোমাকে বললাম না বাড়ি চলে যাও, যাও যাও তুমি ওখানে যাও। আরে ওই বসে মোবাইল দেখবে, পেশেন্ট এলে গুগল টাইপ করে দেখে নি, মারবে। পেশেন্ট বেরিয়ে গিয়ে গুগল করবে, পেশেন্ট বেরিয়ে গিয়ে গুগল দেখবে, ঠিক আছে? এবার ডাক্তার আপনি বললেন ওই সাইড ইফেক্ট। হ্যাঁ, চারটা তাদের ক্লাসে কিন্তু শুনলে বসে বসে, চারটা তোমাদের ভবিষ্যতের জন্য বললাম, আমার তো মনে থাকা জন্য তাই এতক্ষণ ধরে বকলাম। তো বললাম তো 5 মিনিটে ক্লাসটা শেষ হয়ে যাবে, এতক্ষণ ধরে কেন বকলাম আমি? মাথাতে ঢোকাতে চাইছি আমি তোমাদের। বলো এটা, যাও 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 ওখানে যাও। হ্যাঁ, তো কি ডায়াগনোসিস কি? আমি লিখেছি কি ওপর ডায়াগনোসিসটা বলো তুমি আগে। ব্যাকটেরিয়াল বললে 7 কাণ্ড রামার পরে সীতা কার কাবাব। ব্যাকটেরিয়াল বললে, চলো ব্যাকটেরিয়া বললে, কেন বললে ব্যাকটেরিয়াল বলো আমাকে, কেন ব্যাকটেরিয়াল বললে বলো? ওটা তো করা হয় না, ছাড়া ওটা বাদ দিয়ে করো না। আমি বারবার বলছি তোমরা নর্মালি সেম দেখে বা বায়োকেমিস্ট্রি রিপোর্ট দেখেই ডায়াগনোসিস করে দিতে পারবে। আর যদি বায়োকেমিস্ট্রি থেকে কোনো কারণে ডাউট থাকে, দিস আর ক্লিয়ার কেসেস, যদি ডাউট থাকে তখন তুমি বেসিক্যালি প্যাথোলজি সেল টাইপ একটা সেল কাউন্টারে কোরিলেট করতে পারবে। হোয়েন ইউ আর ইন ডাউট, আজ ইন্ডিভিজুয়ালি যদি তুমি দেখো, আইদার ইয়েটা দেখো বায়োকেমিস্ট্রি রিপোর্ট দেখো, কিংবা ইয়েটা দেখো প্যাথোলজি বা হিমাটোলজি সেল রিপোর্টটা দেখো, দুটো রিপোর্ট যে কোনো একটা রিপোর্টে কনফার্ম করে দেবে। ওটাতে ছেড়ে দাও, ওটা করা হয় না। আমি ইচ্ছা করে তোমাদের লিড দেওয়ার জন্য দিয়েছিলে, সেটা ওই মেয়েটা বলতে পারছে না। তুই সারা ক্লাসে কিছুই শোনো নেই, সারা ক্লাসটাতে কিছুই শোনো নি, মানে অ্যাটলিস্ট 10 বার আমি বলেছি কোয়াগুলাম কথা। দেখতে পাচ্ছি না প্রোটিন কোথায় বেড়েছে, কোথায় বেড়ে গেছে। আমি বললাম না এটা 5000 কেস ছিল, ব্ল্যাক অ্যান্ড হোয়াইট বলে দিলাম এটা কেসটা টিউবারকুলোসিস, অন্য কিছু হবে না। প্রোটিন ইজ সো হাই, আর লুক অ্যাট দ্য সেল কাউন্ট। এই ব্যাকটেরিয়াল হতো, আর ওই জায়গায় প্রোটিন থাকতো, এই সেল কাউন্টে অলমোস্ট প্রায় 1 লাখের কাছাকাছি, পুরো 50,000 কাছাকাছি চলে যেত। তখন প্রোটিন পারমিবিলিটি অনেক হাই হয়ে যেত। ক্রনিক ইনফ্লামেশন, ক্রনিক increased in the permeability of the protein হয়েছে বলেই ওই প্রোটিন লেভেলটা বেড়েছে। ইন অ্যাডিশন আইজিজি হয়তো সিক্রেশন হয়েছে, যেহেতু লিম্ফোসাইট ছিল, যেখান থেকে আইজিজি সিক্রেশন হয়েছে। চেষ্টা করেছে ওইটা টিউবারকুলোসিস এটাকে ম্যানেজ করা। পড়াশোনা করো বাবা মা, এখানে বসো। সরি, এই পিকচার হলো তোমাদের যে দুটো ব্যাচ অনেকটাই ভালো বলেছিল। তোমরা এত ভালো প্রেজেন্টেশন করো, এত সুন্দর ক্লাস দাও, তো এভরিবডি ইজ হ্যাভিং সাচ গুড অ্যামাউন্ট অফ পোটেনশিয়াল, বাট হোয়াই ডোন্ট ইউ কনসেন্ট্রেট ইন দ্য ক্লাস? তোমাদের ব্যাচের মধ্যে বলে দিচ্ছে ছেলেরা, এটা বলো। তুমি বলো, তুমি এদিকে এসো, ওই কর্নার থেকে তুমি এদিকে এসো তো, আর তুমি ওই দিক থেকে এসো, এদিকে এসো, দুজনে মিলে। কোনাতে বসে থাকা, কোনোদিন কিছু দিয়ে সামনে বসবে না, বলো কেন বলো, বলো ডাক্তারি করতে হবে, ছাড়ো এদিকে এদিকে এসো। 2 দিন পরে ডাক্তার খাবে, আর কাউ কিছু বলতে হবে না, এরা দুজন আসুক বলুক। হ্যাঁ, ওদের কিছু শুনতে হবে না, এদিকে এসো। এই যদি শুনলে আমার কি বলবে, তুমি কি করলে? তোমাদের কাউকে কথা বলতে বারণ করলাম না। কে কত শুনছো সব আমি দেখতে পেরেছি। হাত তোলা দেখি বুঝতে যা, এখানে বলো, বলো তুমি বলো। ভাইরাল, এ বলেছে ভাইরাল, তুমি কি বলছো? হ্যাঁ, আর তুমি ভাইরাল ফেভারে কথা বলো, যুক্তি দাও, 1 2 3 4 বলো, কেন ভাইরাল বললে বলো, বলো। এখন আমি ছাত্র, আমাকে বোঝাও। তো আন্ধারে হাত পুরানো হচ্ছে, বুঝলে? আন্ধার দিয়ে রুটি খাচ্ছে, বলো বলো। আন্ধার দিয়ে রুটি খাওয়ার গল্পটা আমি বলছি তোমাদের, আন্ধার দিয়ে রুটি খাওয়া। হ্যাঁ, সেল কাউন্টে তুমি দেখালে, সেল কাউন্টের দিকে তাকিয়ে, সেল কাউন্ট দেখি ওইটা ডায়াগনস্টিক ক্রাইটেরিয়া। কি জিনিসটা ভাইরাল ডায়াগনস্টিক ক্রাইটেরিয়া ওইটা? তুমি বলো। হ্যাঁ, কি এটা কি ডায়াগনোসিসটা কি? ভাইরাল। কালার তো নর্মাল হতে পারে, ওটা নর্মাল হতে তো নর্মাল কালার তো হবে। চিন্তা করো, চিন্তা করো, প্রম্পট করছে বসে বসে, যে যখন যখন নিজে ছিল তখন বলতে বললে পারো না। ওই সোজা বাইরে থেকে অভিনয় করো, খুব সোজা ব্যাট খেলা, ক্রিকেট খেলা দেখাও, সব হয়ে যায়। সেল কাউন্ট, সেল কাউন্টে বেশি, আর সেল কাউন্টে বেশি তো ইয়ে তো ব্যাকটেরিয়াল হতে পারে, আর্লি ব্যাকটেরিয়াল ইনফেকশন যদি হয় তাতেও তো হয়ে যেতে পারে। টিউবারকুলোসিস তো হতে পারে। টিউবারকুলোসিস হলে তো এরকম জিনিসটা পেতে পারো একটু আর্লি আর্লি প্রেজেন্টেশন করলে। এগুলো তুমি বলো, আরো মাথায় কিছু ঢোকে নেই। কে বলতে পারবে এটা ভালো করে বোঝাতে পারবে? চলো যাও, তুমি তো বললে একবার, তুমি বলো এদিকে এসো, তুমি তো ভালো, তুমি বলে না কালকে ইকুয়েশনারিক্স কে বললো? তুমি না কে বললো? ইকুয়েশনারিক্সটা কে বললো? হ্যাঁ, তুমি ইকুয়েশনারিক্স এদিকে এসো, ইকুয়েশনারিক্স খুব ভালো বলেছো। তোমার টার্ন হয়ে গেছে, বাস ও চলে যাও, বাস ও জয়েন্ট এন্ট্রান্স পরীক্ষা 10 বার হয় না, সেদিনই হয়, সেই বেলাতে যা রেজাল্ট হলো ওটাই। চলো আগে, খুব ভালো তুমি ইকুয়েশনারি বলেছো, মানে রিয়েলি গুড ওরেশন। থ্যাংক ইউ ভেরি মাচ, তুমি বড় টিচার হবে, ভালো টিচারিং টিচিং লাইনে যাও, যাও এক্সপ্লেন করো, যাও 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 সামনে যাও। হ্যাঁ, কাউন্টটা মোর আছে, আর কি আর কি দেখবে, আর বলো। সেল কাউন্টটা তো নর্মালি দেখা, ঠিক আছে, সেল কাউন্টটা বাড়তে পারে, অল্প বেশি পেয়েছে। ভাইরালে লিম্ফোসাইট, ভাইরাল আর ব্যাকটেরিয়া ইয়েতে টিউবারকুলার লিম্ফোসাইট পাবে, এটা পাবে, কিন্তু ওই প্রোটিনটা তখন ওই ডিসপ্রপোর্শনালি অতটা পাবে না। দেখো, এটা যদি টিউবারকুলার হতো তাহলে প্রোটিন লেভেলটা কিন্তু অনেক অনেক বেশি হয়ে যেত। কোয়াগুলেন্টে ছেড়ে দেয়, আবার বলছি কোয়াগুলেন্ট করাই হয় না, 12 ঘন্টা কেউ সিএসএফ রাখে না, তার আগেই ডায়াগনোসিস হয়ে যাবে। ওই যদি সেল কাউন্টটা থাকতো, ওই প্রোটিনটা কিন্তু 70 থাকতো না, ওই 700 কাছাকাছি চলে আসতো, 700 না হলে 500 উপরে থাকতো। ব্যাপারটা বোঝা গেল? হয়তো গ্লুকোজটা 40 থাকতে পারতো, ব্লাড গ্লুকোজ নর্মালি যদি এটা হাই থাকতো।